Okay, so with the general paper, these are the areas, the distribution areas that you should focus on. So we have medical surgical nursing, we have ethical and legal issues in nursing, we have obstetric nursing, we have pharmacology, public health, pediatric nursing, anatomy and physiology, nursing theories, and psychiatric nursing. Okay, you should expect questions coming from all these angles. Depending on the set you'll be writing, yours may start from obstetrics. Others, your own may start with medical nursing. With the medical nursing, expect questions from everywhere. Just that mostly with the medical nursing, they are going to ask you a lot of questions. This time, mostly on the communicable diseases. Okay, so with the medical surgical nursing under the medicine, they will ask you a lot of questions on the communicable diseases and then sexually transmitted diseases, sometimes on the causative organisms and other times on the medical management. Okay, good. And then also pharmacology is also one area that you should expect questions on. Okay, so let's quickly begin with some of these areas like ethical and legal issues in nursing. I'm going to be very brief because I've encountered you, I've engaged you on these areas before. So with ethical and legal issues in nursing, you should know about code of ethics. So when we say code of ethics, it's simply a set of guiding principles, okay, and professional standards that direct nurses how to conduct themselves, how to take decisions, how to relate with patients, and how to even relate to their colleagues as well as the society. That is code of ethics, okay, or more like ethics. So when we say code of ethics, they are like standards, okay, they are like guiding principles that informs you on how to even make a decision, okay, how to conduct yourself, meaning how to behave, okay, in fact, how to even relate to your patients, their relatives, relate to people in the community or the society, and even to relate with your colleagues, okay, those accepted principles, all that is all you mean by code of ethics. Okay, now we have this international body, International Council of Nurses Code of Ethics. Pay attention to this. The International Council of Nurses Code of Ethics. In fact, when it comes to Ghana, the authority responsible for instituting our Code of Ethics or enforcing these principles is the Nursing and Midwifery Council. Okay, they issue code of ethics for the nursing profession in Ghana. But we have this international body, International Council of Nurses Code of Ethics. Okay, this is a globally recognized international body. Okay, now according to this international body, they have established 4 fundamental functions of a nurse, and every year they will ask you a question on this. 4 fundamental responsibilities of a nurse. So according to ICN Code of Ethics, they say every nurse, you have 4 responsibilities. Once you are within any field of the nursing profession, you have these 4 fundamental responsibilities. So to promote health, to prevent illness, to restore health, and to alleviate suffering. These are your responsibilities as a nurse. Okay, to promote health, to prevent illness, to restore health, and to alleviate suffering. Sometimes they may frame the responsibility in a certain way. So there are times they can ask you that according to the International Council of Nurses Code of Ethics, you understand that the responsibilities of a nurse include all the following, except. Then they may reframe any of them. In fact, study these 4 responsibilities very well. If they project to you or present to you any responsibility that does not align with this 4, it's not part of it. Okay, so it's just about you steadiness. So promoting health, preventing illness, restoring health, alleviating suffering. Sometimes they can choose to do alleviating pain. Sometimes they may alter the words, use some synonyms just to confuse you a little. Just pay attention to it. Okay, good. Now with ethics, so we have ethics, values, and morals. Okay, ethics are more like the standards. When we say an ethics is like a standard. Let me give you a typical example. You know that, for example, in most hospitals, let's say the reporting time for, let's say, duty, maybe 8 a.m. in the morning. Okay, someone can have a belief that, okay, I would always report to work. Let's say I would always report to work 7:30 a.m. before the time, but that is not the standard. It's the person's value. Value is what you believe in. Okay, value is more like, it's like an ideal belief that shape your behavior in decision making. That is value. It's like your personal thing. Okay, that is value. Value is not the standard. Okay, but some people may have certain values. Is that okay? Good. And then we have ethics. The ethics is the supreme. Ethics is the standard. What the system considers to be right or wrong. Okay, professionally. Okay, what the system accepts as the standard, that is ethics. Okay, as the professional standard, that is ethics. People may have other values. Okay, values like being honest, values like being compassionate, okay, respect for human dignity. All that are typical examples of values. And sometimes values help to strengthen ethics. Okay, morals, on the other hand, are more like religious. They are more like, morals are more like beliefs that are influenced by your culture or religious affiliation. So sometimes some people may be or may come from certain cultural background, and they may adapt certain morals. Okay, so for example, Christians have certain morals. So you can find a Christian in a nursing profession who may demonstrate certain behaviors because of the cultural belief or because of the religious beliefs. Those are morals. Okay, good. So then let's go straight to ethical principles. Now let's pay attention to this 6 ethical principles. So autonomy, beneficence, non-malfeasance, justice, fidelity, and veracity. These ethical principles. Okay, so autonomy, beneficence, non-malfeasance, justice, fidelity, and veracity. Now, when we say autonomy, respect for patient choices. Respecting your patient choices. Okay, considering the patient as having that right to accept, your decision, okay, or reject your decision. Okay, autonomy, respecting your patient choices, respecting your patient's right to make decisions. Okay, then we have beneficence. So in a situation where a nurse, you are to administer a treatment to the patient, you are seeking patient consent, you are observing autonomy. Okay, beneficence means promoting patient well-being. Now, mostly in the exams, look at these two. In the exams, most of the time, the examiner is going to examine you on beneficence and non-malfeasance. Majority of the time, in ethics, they are always going to examine you on these two, beneficence and non-malfeasance. Okay, now, beneficence means promoting the well-being of patients. For example, providing comfort care. Okay, for example, patient is in pain. A nurse is going to administer painkiller. That is beneficence. But I will show you how a non-malfeasance statement will be placed. in a non-malfeasance statement, the examiner is going to give you a scenario. Then at the end, is going to give you another side of a statement, indicating that a nurse is making an attempt to prevent an error or injury. Such a statement is non-malfeasance. So, for example, a nurse is going to administer a painkiller for a patient who is in pain. That would have been beneficence. If the examiner had a statement like, okay, the nurse make an attempt to check expiry date of the medication to prevent medication error, that is non-malfeasance. So anytime the examiner gives you a scenario, gives another additional, let's say, another additional statement on the side, indicating the nurse is making an attempt or taking a decision to minimize an error, to prevent harm, then the nurse is now looking at non-malfeasance. We will look at some examples later on. So let's look at these examples. Look at this. So non-malfeasance, you see, checking patients' allergies before administering antibiotic to avoid harmful reactions. That is non-malfeasance. Okay, you are going to administer medication to an antibiotic to patients. You are trying to do an assessment to find out patients' allergies. Okay, so you see, the examiner will make emphasis on a positive statement. Then I will come in with a statement that the nurse is taking a certain action to minimize error or prevent harm. Once you see a line of statements or scenario like that, they are talking about non-malfeasance. But beneficence is always going to be straight positive. Beneficence is always going to be straight positive. Okay, great. So let's look at another example of non-malfeasance. You are using proper lifting techniques to safely move a patient and prevent injury. So you see, the examiner will always add another statement that is indicating that the nurse is taking a certain action to prevent harm or injury. Once you see a statement like that, they are talking about non-malfeasance. Okay, good. Now, justice, on the other hand, means fairness and equity in care, treating all patients equally, irrespective of their background. So if you happen to have even your relative on the ward, treating them, you have to treat your relatives and the other patients equally. Okay, irrespective of their political affiliation, whether their political affiliation, religious affiliation aligns with your own, you have to treat them equally. That is justice. Now, justice, remember that these ethical principles, they do not only apply to the patient, they also apply to the nurses, your colleagues. Okay, majority of the time, a lot of people are thinking it only applies to. So justice, treat your colleagues also equally. Justice, you're a nurse in charge. You have to ensure equal distribution of resources, both to morning shifts, both to afternoon shifts, both to night shifts. They apply to, the ethical principles applies not only to patients, to their relatives, and to your colleagues. Okay, and to members in the society. Okay, fidelity, keeping your commitment, fidelity. Okay, or keeping your promise. That is fidelity. Community health nurse, you went for home visits. When next are you coming? You said I'll come next week. Meanwhile, it's a lie. You will not come next week. Fidelity. Okay, keeping to your promise. You tell patient that the case study, you are going to do 3 home visits. 1 home visit you didn't even do. Fidelity. Is that okay? Good. So veracity, telling the truth. Okay, veracity is telling the truth, being honest about diagnosis. Patients, relatives ask you about something. Instead of, if you know you are not going to tell the patient's relatives the truth, just don't tell them. Okay, as a nurse, these are ethical principles that you have to uphold as a nurse. Okay, so veracity, honestly explaining the side effects of a medication instead of withholding the information. So patient asks you about the side effects of medication. If you don't know, you don't know, but don't lie. Is that okay? You have to be honest. Fidelity, keeping to your promise to update patient. You tell patient family that you are going to update them on the progress of the condition. You didn't do, you promised them, you didn't deliver. If you can't deliver, don't promise. Okay, either than that, you go against these ethical principles. Distributing hospital resources fairly. Let's look at these questions. These are sample questions from the previous exams. According to the International Council of Nurses Code of Ethics, the fundamental responsibilities of a nurse include A, promote health, preventing illness, restoring health, and alleviating suffering. B, managing hospitals, leading policies, reforms, and controlling budgets. C, conducting laboratory tests and dispensing drugs. What would be the correct answer? Yes, what would be the correct answer? Hello? What would be the correct answer here?
Sir, please read the question.
A.
Oh, the question is on the screen. The question is projected on the screen. According to the international... Okay, the answer is A. All right, that is fine. Let's look at question 2. Which of the following scenarios best illustrates the principle of non-malfeasance? Respecting a patient decision to refuse surgery. B, ensuring equal care is given to all patients in the emergency room. C, double checking a medication dosage to avoid patient harm. D, being honest with the patient about side effects of drug. Okay, double checking a medication dosage to avoid patient harm. That is brilliant. So you see, the nurse is making a certain check to avoid harm. So once you see a line of statement like that, they are talking about non-malfeasance. Okay, that is fine. Let's look at the ethical theories. Now, we have these 5 ethical theories that they would always present to you. The ethical theories. So the ethical theories, we have consequentialism, we have deontology, we have teleology, utilitarianism, and institutionalism. These ethical theories. Okay, good. Now, ethical theories are like theories that sort of institute right or wrong. Okay, they are like standard theories that they decide whether a decision or a behavior is right or wrong. Now, the first one is consequentialism. When we say consequentialism, someone who believes in consequentialism, what they do is that they are always concentrating on the outcome. They focus on the results. They are not interested in actions. So, for example, if a consequentialist comes to your ward, let's say a patient is in pain, consequentialists, what they will come and look at is, okay, the patient's problem was pain. What have you been able to control the pain? So if they come and let's say now the patient is saying that, okay, I'm no more in pain. Is that okay? They are okay. They will consider whatever you did, the action you carried on, they will consider it to be right. Okay, they are not going to look at probably maybe you stole someone's medication and gave it to the patient, which is not ethically right. Another example, it could be that you even gave the patient an overdose of a painkiller. You even gave the patient a medication that patient is allergic to, which may go against non-malfeasance. Do you get it? It could be you even gave the patient an expired analgesic, which goes against non-malfeasance. Is that, but consequentialists will not look at all that. Consequentialists will come and look at the results. Patient was in pain. Pain has reduced. You are right. That is consequentialism. Patient is in pain. Pain has reduced. You are right. Okay. Another typical example. Let's say you don't have gloves on your ward. Consequentialist came. Now you have gloves. Nurses are working. There are gloves. That is it. you are right. Whatever happened for you to get the gloves, you are right. It could be that you went to another ward to go and stole gloves. Is that okay? It could be you got the gloves through, an unethical manner or way. You are once, but the consequentialists won't look at all that. Consequentialists don't care about the actions that were taken, whether they were ethical, whether they are just interested in the results. Once the results is positive, whatever action was taken is right. That is consequentialism. Now, the next ethical theory is deontology. Okay, if you don't understand any points, let me know so that I would re-explain. Now, the next point is the deontology. Okay, deontology. Deontology is like a duty-based. Yes, please. Yes.
The one you just finished explaining, the consequentialism.
Okay.
Please, you said that they don't care about how you did it. They're just mindful of the outcome.
Yes.
So even if you use the right step and then they end in the wrong way, they are okay with it. Okay.
So don't even talk about consequentialism. Don't even hammer on the decision that was taken. They are not interested in the decision that you took. They just come and look at the results, the outcome of the action. Okay, so if a consequentialist comes, they are not even coming to check your results. They are coming to measure your outcome. Consequentialists will not come and get time to come and look at your results. They are just coming to check your outcome. Your outcome, is it good? If your outcome is good, whatever action you took is right. That is it. Whether it was ethical or unethical, it's right. That is consequentialism. Okay, so they judge right or wrongs based on the outcome. Okay, so and that means that if they come and the outcome is negative, whatever you did is wrong to the consequentialist. Okay, it's simple as that. Now, deontology, on the other hand, deontology is more like duty-based ethics. So that means deontology is more like opposite of consequentialist. Okay, so that means deontologists, if they come, they are not coming to check your outcome, your results. They are coming to check whether you observed ethical principles. Okay, if they check and you observe ethical principles, even if your outcome is negative, you observe ethical principles, deontologists will consider your actions to be right. That is deontology. Okay, so if whatever action that you took, if the outcome is even negative, but then you observe ethical standards, whatever happened, you are right. That is the deontology. Okay, so for example, let's say a patient was in a respiratory distress. You did what is expected of you ethically. Patients died. Deontology will judge you to be right. Another example, let's use even the same painkiller. Let's say a patient is in pain. Okay, a patient is in pain. Patient's supposed to take, let's say, 1 gram of paracetamol. You gave exactly 1 gram. Okay, pain didn't subside. In the end, patient died. Deontology, when they come, they are coming to check, okay, did you give exactly the 1 gram you expected to give? Yes, you gave. Did the patient die? Yes, patient died. Deontology, once you observe ethical standards, deontology will judge you right. Okay, that is deontology. So deontology, they are not interested in the outcome. They are interested in the action, whether it followed or it aligned with ethical standards. That is deontology. Now, the next ethical principle or theory, the next ethical theory is teleology. Okay, teleology, on the other hand, is morality based on purpose or goal. So now listen, teleology is like an aspect of consequentialism. Okay, so you see, with a consequentialist, they look at the outcome, the results. Now, with a teleologist, so for example, let's say you are working in a facility. Someone come, the person wants to use the principle of teleology. they are not going to look at just the results. They will say that, okay, the outcome that you had, will it help the hospital to achieve its main goal? If the outcome that you had, it will help the hospital to achieve its main goal, you are right, irrespective of the action that you took, whether it was ethical or non-ethical. So if a teleologist comes, the teleologist is not going to just look at the results like the consequentialists, who will look at the consequence. Teleologists will not look at the consequence. Teleologists will look at the goal, the main goal, the major goal. Okay, the major goal or the major expectation. Okay, so teleologists say, okay, in this hospital, our goal is to provide the highest standard of care. Okay, now, in ward A, someone has stolen a patient's medicine and then given it to another patient. The patient's pain has reduced. The patient's infection has been controlled. But then it was a stolen medication that was used on the patient. Now, that has helped them to achieve or render or deliver higher standard of care to the patient. So that means they've contributed to the goal of the facility. Is that okay? But then the action they took is wrong. Teleology will judge them to be right. With teleology, morality is based on whether what you did, okay, you've contributed in achieving or realizing the goal, okay, and purpose of the facility. That is teleology. Okay, good. So, for example, see, providing treatment aimed at restoring independence. So maybe your facility, one of your goals is restoring independence of patients. Then maybe someone do something for a patient, but then unethically. But still, even though unethically, still, it was able to align with the main purpose of the institution. This time, not the results, the goal. Don't see teleology to be different from consequentialism. Just that teleology is going beyond just the results and now going to look at the main goal, the main objective, okay, the main purpose. Okay, then we have utilitarianism. Utilitarianism is also a subtype of consequentialism. Utilitarianism. Now, utilitarianism, the actions will be confirmed right if it provides greatest good or if it saves life. Okay, now let me repeat it again. When we say utilitarianism, they decide that an action, or they confirms an action is good if it is able to benefit a greater number of people, or it is able to save life reasonably or logically. So if the action that you took, if it was able to save a greater number of people's life, or it is able to save an individual's life logically, all comes under utilitarianism. Okay, so for example, in an emergency situation, you have, let's say, 5 old men. No matter what, you know they will die. You have, let's say, 20 infants who you know they are strong enough to survive. And then there is shortage of oxygen. You give the oxygen to all the young people, and all of them survived. Okay, that is utilitarianism. Utilitarianism will confirm your action to be right, even though you didn't meet ethical standards, because ethically, you are supposed to treat all patients equally. Do you remember that? Ethically, you are supposed to treat all patients equally. But because of utilitarianism is going to judge your actions based on whether your action benefited a greater number of people or it saved life logically. If you were able to save life logically, that is utilitarianism. Institutionalism, on the other hand, is when you are using your intuitions, your conscience. For example, if you want to pamper a child who have been given an injection, the child is crying, you don't need any ethical principle. You don't need any standard practice on the ward. You use your intuitions. Okay, all those things comes under institutionalism. Is that okay? Good. For example, you want a patient is very anxious. You want to talk to the patient. Okay. A patient after wound dressing, patient has been given painkiller, patient is very uncomfortable, patient is anxious, patient is worried. If you are going to talk to say you don't need any ethics or whatever. Sometimes you are going to use your intuitions. Okay, so a typical example, a nurse is instinctively comforting a crying child without needing a policy to direct. You use your intuitions. Okay, you use your intuition. Sometimes some will sing for the child, sometimes some will try to play with the child. All those things, you use your intuitions. Okay, let's look at this example. Then you tell me the answer you go for. A hospital has only one ventilator left. The healthcare team must decide whether to give it to an elderly patient with low chances of survival or a young trauma patient with high chances of recovery. The team decides to allocate the ventilator to the young patient because it will save more years of life. This decision best reflects which ethical theory? B. Okay. Utilitarianism. That is excellent. So with utilitarianism, it's more like we are looking at the action you took. Was he able to save greater number of? So in this context, you realize that it's about the aspect of utilitarianism where it saved life reasonably. Utilitarianism is in two phases. So whether the action you took, it was able to save greater number of people. So for example, in an emergency scene, in an accident scene, okay, then a nurse or someone take a decision, then the person is able to save, let's say, greater number of people, let's say 40 out of, let's say, 60 people. Okay, instead of saving all of them, the person saved 40 out of, that still falls under utilitarianism. Okay, or in two situations, two cases, just like we have in this scenario, then you take a decision to save one logically. That one is also utilitarianism. So it's in two folds. Okay, good. Now let's look at the aspect of the legal issues. Now with the legal issues, we have law. Law is a system of binding principle. Law is like some set of principles that is established by a state, sometimes established by institutions or regulatory bodies that shape the behaviors. It spells out what is right or wrong, and it also assign punishment to certain wrong behaviors. That is a law. Okay, that is a law. Now in nursing, nursing is nursing. Laws are there. We have laws, we have rules, we have regulations that governs and protects the things that we do. And sometimes when you go against some of these laws, you may attract certain punishments, which may include maybe you even losing your license and all that. Okay, in nursing profession, the nursing and midwifery is responsible for all these regulations, rules and regulations, standards of practice and all that. Okay, good. Now, with laws, okay, with laws are very important because it protects patient rights. And also, it ensures professional accountability. It safeguards nurses from malpractice or misconduct and claims. Now, let's go straight to the types of laws and its relevance. Now, with the type of laws in nursing, we have two. We have criminal law, we have civil laws. Okay, criminal laws and civil laws. Criminal laws and civil laws. So under criminal laws usually deals with crimes against the state. Mostly for criminal laws, the penalties or punishments may include penalties or even imprisonment and fines. With criminal laws, the punishment may include imprisonment and fines. So if we say a law is a criminal law, look at the statement they've given you. Do you think the punishment to that statement is something that imprisonment is worth it or fine is worth it? But typical examples of those criminal laws in Ghana, see, in nursing, we have murder, manslaughter, kidnapping, assault, and battery. All these if the examiner is talking about all these, they fall under criminal laws. So murder, you intentionally kill a patient deliberately. So you decide to deliberately give overdose of a medication to patients. Patient takes the medicine, patient dies. You see, deliberately. Okay, it was intentional. That is a murder. Manslaughter is unintentionally killing due to reckless action. Okay, so maybe you didn't really preconceive, but because of reckless action, patient died. Maybe you gave a wrong medication to the wrong patient. Okay, or you give a medicine to the wrong patient. At the end of the day, patient dies. That is manslaughter. It's unintentional. Murder is intentional, manslaughter unintentional. But then how will make a manslaughter is when there is loss of life or property. Okay, when there is a loss of life or property. Once there is no loss of life, it will go under civil law. Okay, so for example, you give, let's say, a wrong medication to another patient, but a patient didn't die. That one will go under civil law. It will go under negligence. Manslaughter comes in when there is loss of life. Please pay attention to the trickle. Pay attention to it. So manslaughter will come in when there is loss of life. Okay. So a typical example is, let's say, you fail to raise patient bedside rails. Listen carefully. You fail to raise patient bedside rails. Even though it's your duty as a nurse to do that, you didn't raise the side rails. Patient fall down and die. That is manslaughter. Is that it wasn't intentional, but then it was because of your reckless action. Is that okay? Great. So that one happens to be manslaughter. Another example is you are going to give a medication. You've been asked to give, let's say, 1 gram. You gave 2 grams. Patient died. Okay. Even though you didn't preconceive, okay, it wasn't your intention. But then we are looking at the weight of the outcome. Now, patient died. That comes under manslaughter. Is that okay? So manslaughter comes in. We can have the same scenario where patients didn't die. So sometimes pay attention to the scenario that has been given. Pay attention, okay, to the scenario that has been given. Look at the outcome. Once killing comes into the scenario, they are heading into civil laws. Okay, so we have murder, we have manslaughter, we have kidnapping, we have assault, we have battery. Okay, kidnapping, moving or detaining a patient against their will. That is kidnapping. Okay.
Question.
Yes, please ask your question, young lady.
Sir, please, the definition I'm seeing over here for kidnapping.
Okay.
I've seen a question where they said, like, the patient is refusing medication or the
All
patient
right.
is refusing to make payments
Okay.
before being discharged, but the patient
Yeah.
wants to leave.
Okay.
The nurse detains the patient in a room or lock him up.
Yeah, that
Uh,
is kidnapping. So
they
mostly, you see, most of you think kidnapping is, let's say, a midwife has kidnapped, let's say, a newborn baby. That is how the angle you people see kidnapping. Do you know that if, let's say, for example, you went on a night duty, okay, you've gone on a night duty, okay, I'm coming. Let me see. You've gone on a night duty. No, that one is false imprisonment. Okay, I'll come to that one. That one is a different
that's what
aspect.
I wanted to ask.
That is false imprisonment. But with kidnapping, let me give you a typical example of kidnapping.
Okay.
Let's say you've gone on a night duty. Maybe there has been a change. Patient maybe the team has decided to transfer patient to, let's say, a different facility or a different unit or a different ward. You initiate the transfer without consulting the patients, without consulting the relatives. That is kidnapping. Okay, that is kidnapping. And don't look at kidnapping at the angle from only, let's say, a nurse, then, or maybe a midwife kidnap a patient or a child. No, That is not the only where you can say there is kidnapping. Okay, even if you should detain a patient, okay, without the patient consent. So, for example, a patient has reported to your unit, then you admit the patient somewhere. Relatives are not aware. Patient is not even aware. Say you not allow patient to go. That is also kidnapping. Okay, that is kidnapping. So a patient has come to your facility. They have not given their consent to be admitted. You forcibly admit the patient. That is also kidnapping. Is that okay? So moving or detaining patients against their will, that is kidnapping. Okay, and that is how come sometimes some hospitals, they may allow discharge against medical advice. So if once, I don't know if you've heard that on the wards. So a patient would come in that they want to be discharged against medical advice. They will give them that opportunity to go and bring their letter. Then they will sign and discharge them. Because once you detain the patient, you keep the patient in the facility without their consent, it's kidnapping. Okay, and look at it. It comes under criminal law. Yes.
So is it not false imprisonment?
Please, I'm asking of what of
Okay.
the false imprisonment, the
Okay,
difference
so
between the kidnapping
this is
and
false imprisonment. False imprisonment is when you restrain a patient without justification. So, for example, you have a patient on the ward, maybe an elderly person. Okay, an elderly person who... All right, a minute. I'll be with you a minute.
Okay, sir.
Hi guys.
Hey, girl.
Hi, darling.
Miss Betty, continue.
All right, listen to my lectures. It seems you want to feel Devina, come and teach us something, okay? Maybe how to apply makeups or something.
I know, right? Soft glam. Please, one soft glam.
Everybody take your brushes.
All right, darling.
Hey,
Fine girls, yeah.
wow,
Please, how is recording? No, please.
All right. Can I continue?
Yes, sir.
Okay, that is fine. So we have, for example, you have a patient on the ward. Okay, you are on a night shift. Maybe an elderly patient. You want to sleep. Then this patient is not an aggressive patient. This patient is not a patient who may even inflict violence, self-directed violence or other directed violence. Because you want to go and sleep, you intentionally tie the patient. That is a false imprisonment. Is that okay? That is one false imprisonment. Another false imprisonment could be that a patient has been discharged. Okay, a patient has been discharged. I think there is this question there in general paper that they asked once. Patient has been discharged. Okay, then the nurse probably, even if the patient has paid bail or not, okay, you decide to not allow the patient to go. That is also false imprisonment. If you do that as a nurse, it's false imprisonment. And that question, the rationale is that as a nurse in a right health system, if things are working, it's not your duty to prevent patients from leaving the facility. Yes, the reason why we are charged to do that is because there are gaps in the system. As a nurse, it's not your responsibility to decide on whether a patient should leave or not. It's the work of the security. If things are really working in health institutions, that is not the work of a nurse. Is that okay? And some institutions are doing very well with that. Okay, where even if a nurse, the eyes of the nurse are not even on, there is no way you can leave the facility. Some facilities is done. Do you get it? So that is about false imprisonment. Okay, but with kidnapping has got to do with, for example, you are detaining a patient. A patient have not agreed. You've admitted the patient forcefully. Patients have not agreed. You've hospitalized the patient without the patient's agreement. That is a kidnap. Is that okay? Or a patient is in a facility. You detain the patient somewhere, transfer the patient somewhere without his consent, without his knowledge, without his agreement. That is also kidnapping. Okay, so look at the difference between the two very well. Then we have the assault. Assault is when you threaten someone. You threaten to harm someone. It could be a patient. It could be a relative. Yes, please.
What's the difference between the malpractice and the manslaughter?
Okay, we will come to that. We will come to those ones comes under malpractice, comes under civil law. So when I was explaining, I told you that look at manslaughter. Manslaughter, look at the outcome. Please listen carefully. That's why I told you that always look at the outcome. So if the examiner gives you the statement, don't just go and look at the statement and nurse failed to raise side rail. Look at, did the patient die? Look at the outcome before you make the decision on the option to choose. Is that okay? So, for example, you fail to carry on your responsibility. It has led to death. Don't see it under civil law anymore. We'll come to civil laws. Okay, that is where we have the negligence, malpractice, the defamation, and all that. We'll come to that. The slander and the libel. We'll come to that. Okay, good. We have the assault and the battery. So with the assault, threatening to harm someone without physical contact. Okay, that is an assault. So you tell the patient, okay, sir, you're on admission on the ward, you will see. Say I'm the one who will give you medication, you will see. Okay, that is an assault. You've not carried on any physical action, but you are threatening the patient's harm. That is an assault. Battery, if you go ahead to do it physically, okay, if you go ahead to apply a force, then that becomes a battery. So you actually committing that's what you said. That is a battery. Assault is a threat. Okay, now the civil laws. The civil laws is where we have the negligence, malpractice, and defamation. Okay, so a typical example, let's look at misdemeanors. Okay, misdemeanors. Now let's look at controlled drug violations. You misuse a drug. Okay, as a nurse, you misuse a drug on the ward. You steal patients' medications. Okay, you are conniving, taking patients' money, administer narcotics, selling narcotics. All those things comes under controlled drug violations. Okay, misdemeanor are more like minor offenses. So, for example, you are going to perform a procedure for patients. You don't provide privacy. You don't explain. All those comes under misdemeanor. When you see misdemeanor, look at minor offenses. For example, you finish performing a procedure, you document wrongly. okay, or an incident has happened on the ward, because you want it to go in the favor of the nurses on duty, you document in a certain way. That is misdemeanor. Is that okay? Good. You are going to dress patient wound. You instead of wearing surgical glove, you wear disposable glove. Okay, if you are looking at it with law, that is a misdemeanor. Okay, misdemeanor may come with minor offenses. Is that okay? You are going to do something for a patient, you don't explain procedure, that is a misdemeanor. Okay, they usually come with minor offenses. Now, the key area with ethics, the legal issues, is thought in nursing. Thoughts, they are the civil wrongs. The thoughts, we have intentional thoughts and we have unintentional thoughts. So with the thoughts, we have intentional thoughts and we have unintentional thoughts. With the intentional thoughts, we have assault and battery. They come under intentional thoughts. Okay, assault and battery. For example, forcing a patient to take a medication. Okay, forcing a patient to take a medication without the agreement. And or example, you threaten patients. And then you go ahead to, when you are threatening a patient, okay, with assault, it's intentional. You think about it. If you tell a patient that, okay, say we are here on the ward, we will see what will happen. You thought about it before, so it's an intentional thought. Is that okay? You thought about it, you processed it, so it's intentional. Okay, so those comes under intentional thought. If for example, you threaten a patient, you go ahead to do it. You still thought about it before, so it's intentional. So okay, so assault, battery, all comes under intentional thought. Okay, then we have defamation. Defamation is more like a false statement about a patient, about a colleague, about a patient relative. Okay, a false statement about a colleague, a false statement about someone. A patient have not done you anything. You've written in incident book, patient did something. You've written something false about patients in an incident book. It comes under defamation. Okay, false statement about a patient or a colleague, all comes under defamation. Slander. Okay, when we say slander, when you speak orally something false about a patient, if defamation is done verbally, that is a slander. If you write it, that is so. For example, you test another colleague that, so and so, Charlie, this guy, this is what he did. Oh, meanwhile, it is wrong. That is defamation. But then it's libel. Because you typed it. It's libel. But if you speak it orally, it becomes a slander. Okay, good. We've looked at false imprisonment already. Unintentional thoughts. The unintentional thought, that is where we have negligence and malpractice. Pay attention. That is where we have negligence and malpractice. Look at negligence. Look at the example of negligence. Leaving bed rails down, leading to patient fall. You see, we didn't say leading to patient death. If patient dies, this is it. It's manslaughter. Okay, so all the time, pay attention to the scenario. Okay, with the unintentional thought, with the negligence, all the time you are going to see that in the scenario, they are not going to make any emphasis on patient died, they are just going to say patient suffered an injury, patient fell. Then you are thinking of negligence. But once you see leading to patient death, okay, please pay attention and know which one to choose. Okay, so for example, a nurse failing to act, I'll explain what negligence and then malpractice means. If you are not careful, it will confuse you. But what I want you to keep in your mind is that when we say negligence is failing to act competently. And a typical example, let's look at this example. Look at this. So negligence means failing to act as reasonably careful person would be. Okay, negligence can apply in all situations. When we say malpractice is like a professional negligence. Malpractice only applies to professions like nurses, professions like doctors, when they fail to meet professional standards. Okay, now listen. In an MCQ, okay, if you have, they give you a scenario and both negligence and malpractice is there, please go for negligence. Okay, listen carefully. Let me repeat it again. In an MCQ, in fact, this answer, it will be corrected. Okay, but even though this answer, the answer is malpractice, but I'll give you the reason why this answer here is malpractice for you to understand properly. Okay, so in an MCQ, mostly, if you have negligence and malpractice, please go in for negligence. Okay, now let's look at this example. A nurse administers the wrong medication to a patient, causing serious harm. And you know why this is malpractice? This is a malpractice because the nurse administered the wrong medication. Now, in negligence, how would you know that this is negligence? Negligence is when you fail to do the thing competently. Okay, so look, they say a nurse administers wrong medication. The nurse administered it right. It could be that, for example, let's say paracetamol 1 gram. You've gone to give that paracetamol 1 gram. Paracetamol is supposed to be taken orally. Listen carefully. It's supposed to be taken orally. You've gone to give it orally, correct? You've given it orally, but you've given it to the wrong patient. Is that okay? You've given it to the wrong patient. You gave it orally. You gave it how paracetamol is supposed to be given. You gave it the right way. You explain procedure. You ask of the patient right, everything, but you're giving it wrongly. That is a malpractice. When we say negligence, when you fail to do it competently. So, for example, IVP more. IVP more. We give IVP more, IV. You've given it to the patient through oral. That is a negligence. If you are not careful, you not get it. So negligence is when you fail to do it as a nurse is supposed to do. You fail to do it competently. That is negligence. Negligence can also mean that you didn't do it at all, even though it's your responsibility. That is also negligence. Okay, it is your responsibility. You didn't do it at all. It has harmed the patient. Okay, mostly negligence will cause serious harm. Once they tell you that patient died, then we come back to here. We come back here. This one. We come back here. Manslaughter. Once in the statement, they've added that patient died, it comes to manslaughter. But with negligence, and in fact, with negligence, they are always going to end at causing serious harm in the scenario. In negligence, they are always going to say causing serious harm, causing an injury, causing a fracture, causing something. You will see death in the statement. Once you see patient died, come back to this one. It comes here. It's no more coming under negligence. So don't always rush. Look at the scenario very well. What is the end result? Is it death or it is harm? If it is harm, then you'll be thinking about negligence and malpractice. That's why I'm showing you that with malpractice, see, a nurse administers the wrong medication. Emphasis was not made on the fact that the nurse administered it incompetently. He administered the wrong. Probably the nurse administered it how medication is supposed to be administered. Maybe it's 1 gram, the nurse administered it 1 gram, but wrong medication to wrong patients. Okay, that is a malpractice. Okay, with negligence, let's say you are supposed to give a medication, let's say orally. You've constituted, you've messed, you've crashed, you've given it IV. That is negligence. When you fail to do it as a nurse is supposed to do. When you fail to do it as a nurse is expected to do, that is negligence. Or you fail to do it at all, even though it's your responsibility. That is also negligence. Okay, so know the difference between the two. Okay, know the difference between the two. Another example could be for malpractice, for example. Another example of a malpractice could be, let's say, you know that nurses have a way you dress. You decide not to dress that way. Nurses report to work on time. You always don't report to work on time. Those ones all comes under malpractice. So sometimes check the context of the question. Those ones usually comes under malpractice. For example, a nurse, you are supposed to report to work at 8. you report to work, let's say at 9 or 10. That is a more, all comes under, those ones comes under malpractice. When it comes to negligence, it's about your duty, your responsibility. You fail to do it how a professional person is supposed to do it competently. Okay, good. Then that one comes under, or you didn't do it at all and it leads to patient harm. That one comes under negligence. So note the difference. Now, we have legally sensitive practice settings. We have something in ethics we call legally sensitive practice settings. Legally sensitive practice settings are like areas where ethical issues are more likely to occur. So, for example, in emergency units, you don't know the people that you are caring for. Emergency unit is about life and death. So you always have to be very careful when it comes to ethical principles. And moreover, you don't even know whether the person you are caring for, you don't know who the person is. So ethical principles or ethical engagements are key in emergency units. Now, in intensive care units, intensive care units is also another critical zone that you have to be very careful. Sometimes patients are on ventilators, all types of patients, all kinds of patients with different conditions. So in those areas, you have to be very careful. In psychiatric facilities, in pediatric and obstetric facilities, in geriatric and long-term care facilities. Okay, all these areas, especially the other time, someone even mentioned maternity wards and the labor wards and all those things. All these are areas that you have to be on your guard when it comes to legal issues. Okay, because you may not know. For example, the labor ward, maybe someone is about 50 years now having the first pregnancy. Such a case, if you are handling such a case, you have to be very careful. Okay, the least mistake, they will sue you. So you have to be very sensitive with legal issues. Okay, now we have ethical dilemmas in nursing. When we say an ethical dilemma is more like a situation in which a nurse faces two or more conflicting or moral principles. When two ethical principles are conflicting, that is when we say there is an ethical dilemma. So when two ethical principles are conflicting, you are at a junction where you don't know which ethical principle to go for. Then we say there is an ethical dilemma. So sometimes nurses can say, for example, let's say, let me tell you, like, you are at the family planning unit. Two couples have come. Maybe the male partner is having HIV. In ethics, you are supposed to be confidential. You don't know whether to disclose it to the wife or not. Then you see nurses saying, oh, hey, Charlie, this is a dilemma. This is an ethical dilemma. You get it? Meaning two ethical principles are conflicting. You don't know whether to go against one or to side with the other. Okay, that is what we call ethical dilemma. Okay, let's look at some examples. Look, a terminally ill patient refuses life support, but the family insists on continuing the treatment. Okay, so you see the patient himself is saying that, take me off the life support. The family is also saying that, put the patient on the life support. Who do you go for? You see, two ethical principles will be conflicting. See, because as a nurse, one of the things you should observe beneficence. At the same time, you should also observe autonomy. You should respect the patient right. At the same time, you should also do good. So you see, two ethical principles are going to what? Conflict. Okay. Another typical example, a patient asks about poor prognosis, but the family requests the nurse not to disclose it. Okay. The family is telling you, tell the patient that the prognosis is good. Then you, the nurse, that you have to tell the patient the truth. Okay, so two ethical principles will be conflicting. Is that okay? Two ethical principles will be conflicting. Okay, great. So that is it. And another thing is that, for example, you are in an overcrowded ICU or an overcrowded emergency. Then you have some patients, about let's say 10 patients, all of them need oxygen. You choose to give the oxygen to, let's say, their children. Then at the end of the day, even some of them have to even lose their lives. Okay, two ethical principles will be confused. So the nurses can say, hey, Charlie, today the ethical dilemma. So, okay, so meaning they were in situations where two ethical principles are conflicting. Because you see, as a nurse, you should be just, treat all patients equally. Because of the situation, the how sensitive the environment is, okay, you are going on the side of one ethical principles, neglecting on the other. Then we say there is an ethical dilemma, okay, because as a nurse, you are supposed to distribute resources equally, justice, and you are supposed to do good to all your patients. How come the situation is making you do good to some of them? So then there is a dilemma. Do you get it? There is a dilemma. So sometimes you read the scenario very well and know which of the options to go for. So when you pay attention to the scenario, you'll be able to tell that, oh, okay, then this dilemma is autonomy and beneficence. Then you know which option to go for. Okay, good documentation. Documentation is a very important aspect of nursing. Okay, it's one of the areas they ask questions on a lot in the general paper. Now, let's be very straight. Documentation, you are recording patient care. What exactly you did for the patient, the observations, the things that you observed. You are just going to document those things. Okay, maybe you took a decision. You are going to document those decisions. The purpose of documentation is for a legal backing, legal evidence. Documentation is also a means of communication between professionals. Okay, because documentation can help with continuity of care, and it's very essential when it comes to research and editing. Like you at the OPD, the vital signs that you are documenting, the labs that you are all those can be used for research purpose, and then all that can also be used for auditing. Okay, now a good documentation should be complete, it should be accurate, it should be timely, it should be clear and legible, and it should be confidential. Now, pay attention to these 5 characteristics of a good documentation. So, every good documentation, it should be accurate, it should be complete, it should be timely, it should be clear, legible, and confidential. Okay, so you should record exactly what happened. Don't assume and write. The incident happened. Why are you assuming before you write? You document exactly what happened. Okay, it should be complete. All details have to be there. Don't write some to favor you. Write exactly what you observed during the incident. Okay, good. So in nursing, we document vital signs, we record medications after administration them, we document patient responses and all that. After some procedures, we do documentation. In nursing, informed consent. Okay, informed consent is more like a process where patients receive clear, complete, and accurate information about the procedure. Okay, the characteristics of informed consent, we have explaining the procedure, disclosing the risks, and then the risks and complications, benefits and expected outcomes, or alternatives. Okay, so if we say that an informed consent is very good, that consent, in fact, the 2 main things that you should pay attention to, areas you should pay attention to confirm that a consent is good, is 1, explaining the procedure and then letting the patients know the risks involved. Most of the time, that is what they will present to you in the exams. So for every good informed consent, you should explain the procedure. You should let the patients know the complications and the risks that are involved. But apart from that, we have other things. A good informed consent should inform patients about other alternatives to the procedure, the benefits of the procedure, the comprehension, the capacity, the competence. Okay, the competence of the professionals. Okay, you should let the patient, you assure patients of the opportunity for them to put in their questions. And then a good informed consent should be documented. This part is also very important to me. Now, listen, a good informed consent should be written. If they give you a scenario, they said the patient was given an oral consent, or a patient gave an oral, it's not a good informed consent. Under no circumstance, don't go and defend it anywhere. Informed consent should be written. If it is not written, it's not a good informed consent. Every good informed consent should be written. Okay, but in nursing, your role as a nurse in informed consent is to facilitate that patients have understood. Make sure yours is to make sure patients have understood. Yours is to witness that patients have actually signed. You are there as an advocate of the rights of the patient, and also just to record that, oh, indeed, I saw the patients. I overheard the medical team explaining the procedure to the patient, and I witness this signing the consent, patient signing the consent form, or the relative signing the consent form. Okay, so a good informed consent should, it should be documented, it should be written. The patients should receive explanation on the procedure. Patients should know about the risks involved, the benefits, other alternatives. All these forms part of a good informed consent. Now, nursing theories. Now, they are going to examine you in ethics on these nursing theories. Florence Nightingale theory, environmental theory, Virginia Henderson's nursing need theory, Abraham Maslow's hierarchy of needs theory, the Sigmund Freud psychosexual theory, Erik Erikson's psychosocial theory of development. Okay, so these theories are the theories that they are always going to limit themselves to these theories. Okay, Florence Nightingale's theory is about the environmental theory. So when you say environmental theory, they are talking about Florence Nightingale theory. Okay, so Florence Nightingale believes that nursing is about using the environment to assist patients in recovery. So if they tell you, which nursing theorists believe in adjusting the environment to achieve recovery, okay, or which nursing theories focuses on adjusting or making adjustments in the environment to promote patient recovery, then they are talking about Florence Nightingale. So Florence Nightingale definition of health actually focuses on the environment. She believes that if you should put the patient in the right environment, nature will work on the patient and patient will recover. You see her belief. So according to her, she says that, okay, we want the patient to recover. Let's work on the environment. Let's make sure everything in the environment is corrected. Okay, then the patient will recover naturally. So with the environment, okay, she instituted 5 components of environmental factors. She said that if a patient is sick, let's give the patient clean air. Let's give the patient pure water. Let's give the patient efficient drainage. Let's ensure there is efficient drainage. Let's ensure patient is clean. Let's provide the patient with light. Once we give all these things, so 1, 2, 3, 4, 5, they can ask you what are the components of the Florence Nightingale theory. There are 5 components, simple as that. Okay, so according to her, there are 5 major components. 5 major components: clean water, pure water, efficient drainage, cleanliness, and light. Okay, so according to Florence Nightingale, if you are able to correct these 5 things positively, patients will recover. Okay, so clean water, pure water, efficient drainage, cleanliness, and light. Once you correct these 5 things, patients will recover. Okay, nature will act on the patient and patients will recover. So we should focus on giving the patient safe water, clean drinking water, proper ventilation, hygiene, ensuring patients is assisted to bath, adequate sunlight, adequate lighting. Okay, once you're able to provide patients with all these environmental factors, patients will heal. That is Florence Nightingale. So in summary, the theory is an environmental theory. Okay, now the next is Virginia Henderson. With Virginia Henderson, they can present to you her definition of nursing. How did Virginia Henderson do? So sometimes in the exams, they can write their definition of nursing and ask you which nursing personality define nursing that way. So you see, the unique function of the nurse is to assist the individual, sick or well, in the performance of those activities, contributing to health or its recovery, or to a peaceful death that the nurse would have performed unaided if he had the necessary strength, will, or knowledge, and to do this in such a way as to help him gain independence as rapidly as possible. You see how simple it is. So if you see this definition, they are talking about Virginia Henderson. Is that okay? Now, her theory is called the need theory. Okay, unlike Florence Nightingale, who believes in the environmental theory, Virginia Henderson says no. Every patient or every individual has some needs. Once the patient is not well, the patient will have some needs. Okay, for we to do nursing will mean that let's make sure we are helping the patient to be able to do all those needs independently, then we can say patient is healthy. So for Virginia Henderson, she's saying that if a patient is sick, the patient will definitely have some needs. If patient is we are able to care for the patient to a point where patient is able to do those things, then we've administered nursing. That is her belief in nursing. So she instituted 14 basic needs. So if they ask you in the exams that, okay, which nursing personality instituted the 14 basic needs? Okay, then they are talking about Virginia Henderson, the 14 basic needs. And after identifying the 14 basic needs, she further grouped them under these areas: physiological needs. Okay, and it is from Virginia Henderson that we got classification of nursing interventions. You see, sometimes you are reading medical nursing tests, but then they classify them: physiological care, psychological care. All those things are coming from Virginia Henderson. She classified them. Okay, she classified them under physiological needs, safety needs, love and belongings, esteem and self-actualization. Okay, so if they ask you, okay, which nursing theorist instituted the 14 basic needs, okay, of every individual? So every individual has 14 basic needs. And if they are not well, your own is to focus on these 14 basic needs and make sure you assist patients to be able to do them independently. Okay, that is Virginia Henderson. So let's look at some of the 14 basic needs, which has been grouped. So under the physiological needs, we have breathing, we have eating and drinking, we have elimination, we have movement, we have sleep or rest, we have clothing, body temperature maintenance. The safety needs, we have maintaining hygiene, avoiding danger, safe environments. Love and belongings, we have communication, expressing emotions, faith and relationships. All these comes under the love and belonging. Self-esteem, we have work, accomplishment, recreation, learning, spiritual growth. Okay, so Virginia Henderson theory is about the needs theory. Okay, the needs theory. So look here. Look at these. There are 14 components of Virginia Henderson needs. So you assisting patients to breathe normally, eat and drink adequately, eliminate body waste, move and maintain desirable posture, sleep and rest, select suitable clothes, dress and undress, maintaining body temperature within normal range, keeping the body clean and well-groomed, and protecting the integument, avoiding dangers in the environment, communicate with others, worship according to one's faith, work in such a way that there is sense of accomplishment, play or participate in various forms of recreation, learn, discover, or satisfy curiosity that leads to normal and health use of available health facilities. Okay, so these are the 14 components. So these ones, the ones in the diet, these are the 14 components. Okay, the 14 components of the needs that if a patient is sick, make sure patient is able to perform all these things or achieve all these things. Okay, once you are able to do that, that is nursing. Okay, so she said the unique function of the nurse is to assist the individual, sick or well, in the performance of those activities contributing to health or its recovery or to peaceful death that he would have performed unaided if he had the necessary strength, will, or knowledge, and to do this in such a way as to help him gain independence as rapidly as possible. Okay, now the next theory is Abraham Maslow's theory. So Abraham Maslow's theory is the hierarchy. Okay, do you know that prioritization in nursing is coming from this theory? Prioritization. Okay, prioritization, that a nurse, you are going to do things, then you say, okay, let's do this first. So for example, if a patient is in pain, patient is having difficulty breathing, say, okay, in nurse, we say, okay, let's do this first. It's coming from this theory, Abraham Maslow's theory, prioritization. Okay, so the levels of his theory is also called the hierarchy of needs. Abraham Maslow's theory is like an advancement or an upgrade to Virginia Henderson. Virginia Henderson is saying that every patient is having 14 needs. If you want to administer nursing, make sure the 14 needs, you assist patient to satisfy all the 14 needs. Abraham Maslow says that, okay, let's not end there. The 14 needs, some are important than others. That is Abraham Maslow. It's simple as that. Abraham Maslow, and it's logical. Abraham Maslow is saying that the 14 needs, some are important than others. In helping patients to achieve those needs, pay attention to the basic ones. That is Abraham Maslow's theory. That is the whole summary of Abraham Maslow's theory. So you see, both Virginia Henderson and Abraham Maslow, they concentrate on needs. They all categorizes. Okay, so in nursing, when you are reading nursing management, they say, oh, physiological care, psychological care, assessment, observation, wound care, cleanliness. You see, if you are reading the textbook, you see they classify them. It's coming from these two theories, Virginia Henderson and Abraham Maslow. But Abraham Maslow is the one that brought about the prioritization. Have you checked that if you are looking at nursing intervention, sometimes they will say, okay, assessment first, observation first. From there, come to physiological care, come to psychological care, do pain assessment or do pain intervention. Okay, even if care plan you are doing, sometimes some people tell you prioritize, start with the most important intervention first. That one is coming from Abraham Maslow. Abraham Maslow's theory, hierarchy. Okay, prioritization is coming. So Virginia Henderson is saying that we have 14 needs. Abraham Maslow is saying that, okay, I agree with you, but the 14 needs, some are important than the others. Let's start with the basic needs first. Is that okay? So Abraham Maslow says that let's start with the physiological needs first. What are physiological needs? Food. Okay, food, water, oxygen, sleep, elimination. And that's the reason why if patient is having all kinds of needs, these things that patients need for survival, oxygen. Okay, you see, if patient is in pain, patients cannot breathe. You have to tackle the oxygen first because it's a physiological need. If you really understand Abraham Maslow's theory and the elements under it, the classification, you will not have a problem as a nurse when it comes to prioritization. This is where prioritization started from. Okay, safety needs, protection, stability, oxygen, security. So, for example, a patient bedside raise has not been raised. That same patient need oxygen. Which one will you do first? It's the oxygen. Why? From Abraham Maslow's theory, physiological needs first. If you really want to be good as a nurse with prioritization, understand the Abraham Maslow's theory. Okay, so the safety needs, protection, stability, security, ensuring fall prevention in elderly patients, the love and belongings, that's the third. Okay, so look, sometimes they can ask you the question this way, that in the Abraham Maslow's theory, at the base of the pyramid, what is there? At the base of the pyramid, we have the physiological needs. At the apex of the pyramid, what is there? At the apex of the pyramid, we have the self-actualization needs. Sometimes that is how they will present it to you in the question, in the context. So for the Abraham Maslow's theory, at the base of the pyramid, what is there? This is the base. This is not the base. This is the apex. So at the apex of the pyramid, what is there is the self-actualization. At the base of the pyramid, and you see the base is very broad, indicating that those things here are very important. Can you see, as you are down, it's very broad. Okay, and that tells you that the physiological needs are very important for survival. They are the basic needs that are very important for survival. Sigmund Freud's psychosexual theory. Okay, so the Sigmund Freud's psychosexual theory, these things are more like reading things. Okay, these are more like reading things. One of you should quickly read these things and let's move on.
Sigmund Freud's psychosexual theory. Sigmund Freud proposed that personality developed through 5 psychosexual stages, each centered on the pleasure focus of a specific body part. Unresolved conflict at the age may lead to fixation and affect adult behavior. So the 5 stages. The first one is the oral stage, which is 0 to 1 years. This one focuses on mouth, sucking, feeding, and then Nurse's note says provide oral stimulation and then feeding pacifiers. The second stage is the anal stage, which is from age 1 to 3 years. This one focuses on bowel and bladder control. Toilet training, harsh discipline may cause obsession with order or cleanliness. The second stage is the phallic stage, which is 3 to 6 years. This one focuses on the genital, so the Oedipus and Electra complex. So the next note here says encourage positive identification with same-sex parents. The fourth one is the latency stage, which is age 6 to 12 years, focuses on dormant sexual feelings, development of social and intellectual skills. The nurse's note supports schoolwork, hobbies, and then peer relationship. Okay. The last stage is the genital stage, which is 12 years and above. Focuses on maturation of sexuality and independence. Nurse's note, guidance in relationship, responsible sexual behaviors. So the significance in nursing, it helps understand behaviors related to unmet childhood needs. And then the second one is that it supports age-appropriate interventions and psychological care.
Okay. What is the meaning of Oedipus complex and Electra complex? What does it mean? Let me say Oedipus complex and Electra complex, the phallic stage. Let me say Oedipus complex. What does it mean?
So please, with the Oedipus complex, the male son is having is having a feeling for the mother.
Okay.
Then with the Electra complex, the female, as in the daughter, is having a feeling for the carnison, the daddy. That's the father.
Okay, so those are more like connections. So with the Oedipus complex, the male have connection to the man, and then Electra, the female have a connection to the opposite sex. It's more about opposite sex, and that happens in the phallic stage. Okay, in the oral stage, the focus is on the mouth. Okay, so over there is sucking, there is feeding. Okay, and your duty as a nurse is to provide oral stimulations. You can make use of feeding and then pacifiers. With the anal stage, focus on bowel. And this is the time you have to concentrate on toilet training. Okay, between these ages, 1 to 3 years, you have to concentrate on toilet training. And, harsh discipline may cause obsession with others and cleanness. Some people, they are very clean. Sure, some people, if you go to their room, if pen is supposed to be on top of a book, if you put it anywhere, they will be uncomfortable. They will not even be able to sleep. It's coming from this stage of life, the anal stage, the toilet training. People form discipline, harshness, and all this from here. Okay, so if the child, let's say, soils himself, you said, oh, let me wait. Some people, the child will soil himself, say, oh, let me wait. In the evening, then I'll change. That child will grow and take cleanliness to be normal. So the person will be in an environment, the environment will be dirty. You say, oh, let me wait for 1 month and clean the room. They will not care. They will form that behavior from that side. Okay, so it's your duty as a nurse, as a mother, to train the child during that stage. Okay, to train the child during that stage with the toileting. Okay, and once we are able to do that, they form a certain discipline or behavior from there. If you are so straight on that too, the training is so positive, aggressive, the child will also become over orderly. So there are some people, they do their things orderly. They always want things to be done a certain way, or is influenced by some of these theories. Okay, then we have the latency stage. The focus is over there. Then at the latency stage, remember then, at the phallic stage, they focus on the genitals. At the latency stage, there is a dormant sexual feeling. Is that okay? And now the focus is on social or intellectual skills. The child wants to learn something. Sometimes they want to, do some work in school, they want to do some exercises, they want to, play with their peers and all that. That is what happens at the latency stage. The genital stage, the focus is on maturation and sexuality. The child now looking at independence, wants to be independent. Okay, and over here, your nurses notice guidance in the relationship. You have to offer guidance as a mother, educate them on all the sexual risk behaviors and all that. Okay, so that is it about the sigmoid Freud. Now, the key one is the Erik Erikson theory. In fact, they would always ask you one question on this area. It's just up to you for you to just know the thing. But I think sigmoid Freud psychosexual theory is very simple. Now, with Erik Erikson, this is what you use a lot in your case study. You use this a lot in your case study. With Erik Erikson psychosexual development theory, okay, now we have 8 stages. Okay, with 8 stages, the 8 stages, we have infancy. Infancy is between 0 to 1 year. We have early childhood between 1 to 3 years. We have preschool between 3 to 6 years. We have school age between 6 to 12 years. We have adolescence between 12 to 18 years. We have young adults 18 to 40 years. We have middle adulthood 40 to 65 years. We have the late adulthood 65 years plus. Okay, good. And at the infancy, that is trust versus mistrust. Okay, trust versus mistrust. At the early childhood, we have autonomy versus shame and doubt. So over there, you have to support the child to become independent, and it includes practices like the toilet training. Preschool, we have initiative versus guilt, encourage play, decision making. School age, we have 6 to 12 years. Industry versus inferiority. Over there, you have to support the child to learn and then contribute to their achievements. Like school projects, you may have to assist them with school projects, school tasks, and all that. Adolescents, identity versus role confusion. Young adulthood, intimacy versus isolation, supporting them in relationships and commitment. Middle adulthood, generativity versus stagnation. Late adulthood, integrity versus despair. Okay, the significance of this theory is it helps nurses to give age-appropriate care. Okay, because nurses, one of the things we believe in is patient-centered care. If you have this theory at the back of your mind, you already understand at every level of an individual's life, they have certain psychosocial expectations. That is the basis of this theory. Okay, so if you are nursing someone who is between 18 to 40 years, at that stage, they are really interested in relationships and being committed in their relationships. So during the care, those are areas that you also have to factor, because psychosocial parts, aspects of health also contribute to the recovery of patients. Okay, so you have all those things in your mind, and this is something that is done in your patients and family care studies. Okay, let's look at these 2 questions. These are sample questions. A nurse is caring for a 15-year-old adolescent admitted for appendicitis surgery. According to Erik Erikson's stages of psychosocial development, the primary psychosocial task for these patients is identity versus role confusion. Okay, 15 years. So you see identity versus role confusion. Okay, that is 12 to 18 years. So 15 years would be between 12 to 18 years. Okay, let's look at question 2. A nurse observed a 2-year-old child insisting on using the potty independently, but becoming upset when corrected harshly. According to Sigmund Freud's psychosexual stages, the child is in, this is the anal stage, B, the anal stage. Let's look at other examples too. A 70-year-old patient reflects on his life and expresses satisfaction with his achievements. According to Erik Erikson, the stage is best described as a 70-year-old. So look, 70-year-old. Okay, 70-year-old. And I think that is integrity versus despair. Am I right? Am I right? Integrity versus despair.
Yes, please.
Yes,
Yes,
70
please.
years old. Because integrity versus despair is late adulthood. That is 65 years plus. No, if you go for look, the age is 70 years. So if you go for middle adulthood, this is generativity versus stagnation. That is 40 to 65. Okay, so you have to go for the 65-year plus. That is the late adulthood, and that is integrity versus despair. Okay, so always pay attention to the ages. Okay, good. Now let's look at the last one. A 5-year-old child is very attached to the parent of the opposite sex and compete for attention of the same sex parents. According to Freud's psychosexual theory, this behavior reflects what? The phallic stage. This is the phallic stage. That is where we have the Oedipus and Electra complexes and strong identification with parents of the opposite sex. Okay, therapeutic communication. Therapeutic communication. Now, in therapeutic communication, pay attention to these things. These are the key areas I want you to pay attention to in therapeutic communication. The types of communication. Now, the types of communication, we have the passive communicators, we have aggressive communicators, and we have assertive communicators. In nursing, the best is you have to be an assertive communicator. What does it mean to be assertive? Honest, respectful. Okay, we will look at some statements that expresses assertiveness. A typical example is, I feel concerned when instructions are unclear. I feel concerned when instructions are unclear. Could you please explain? This is a typical example of an assertive communicator. Now, in therapeutic communication, I believe you were taught or you came across the use of the word I, the letter I. Most of the time in assertive statements, it begins with I. Okay, assertive communicators usually use I, the I statements. I mostly is used if you want to express a calm tone. Okay, good. So, but aside the assertive communication, let's look at the other communicators so that if they are put in a context, you'll be able to identify them. Like a passive communicator, they avoid the expression of needs. Okay, everything goes. If you say assertive communicator, mostly if you look at the statement, someone is making a statement as if the person is okay with everything. They don't really care. That is passive. So they avoid the expression of needs. It's okay, I don't mind. This is passive. Okay, it's okay, I don't mind. It's passive. Okay. Okay, so someone make a statement that, other people's rights needs to take precedence over mine. The person is passive. Okay, in fact, the passive communicators usually they are emotionally dishonest. It's indirect. Okay, inhibited, self-denying, and then blaming. Sometimes apologetic. Okay, so if you are reading the statement, it's like the person is giving precedence to other people's rights, other people's needs. They don't really seem to care. They don't really seem to be interested in a certain formal way. They don't really seem to want to be involved. It's passive. Okay, good. We have passive aggressive. Okay, and then we even have aggressive. Now, with aggressive communicators are usually hostile, with a hostile tone. Okay, so for example, you are having a conversation to somebody, said, keep quiet, you never listen to me. Keep quiet and listen to me. Usually, those are the aggressive statements. Okay, so with aggressive, they sometimes use inappropriate words, dishonest words. Okay, they sometimes use direct words, attacking words, blaming. Okay, so if you are reading the scenario, it's like blaming, trying to control, trying to take charge. All those comes under aggressive. They are the aggressive. Okay, in nursing, the best communication style is the assertive communication. Okay, good. Let's look at some examples. to a doctor. So let's say I am worried about the patient's low blood pressure. We need to act immediately. Is this assertive? Do you think this is an assertive statement?
No, please.
No, it's an assertive statement.
Yes, please.
Yes, I am worried about the patient's low blood pressure. And I gave you a clue that mostly the assertive statement mostly begins with I. It's not all the time, but at least keep that in your mind that in therapeutics, that principle too is there. Most assertive statements usually begins with I. So sometimes pay attention. They've given you a scenario and they tell you which of them expresses assertive statements. Consider that, because mostly that is something that is mentioned a lot in therapeutic communication. Okay, good. Let's look at this. I prefer we share the workload equally to avoid burnout. Do you think it is assertive?
Yes, please.
Yes. Okay, I respect your decision to refuse treatment, but let me explain the possible risks so that you are fully informed. Do you think it is assertive?
Yes, please.
Yes.
It is.
So the assertive statements, you could see it is the person is being honest with their communication. They are direct. They are self-enhancing. They are very expressive. The person didn't say, "Oh, whatever you say, I'm okay." So, for example, a patient is telling you something, say, "Oh, are you done?" Okay, whatever you said, me, I'm okay. You can go. Okay, assertive. They are going to be very honest, self-enhancing, expressive, self-confident. They are going to show empathy and some level of emotions. That is assertive. So if you read the statement is not showing, expressing any kind of emotion. The nurse don't really care. The nurse don't really mind. The nurse is okay with whatever the patient said. Okay, those ones are usually passive. Okay, but when it comes to the aggressive, even though you don't seem to care, but in addition to that, you are using some negative statements, some harsh words, trying to take control. It's okay. What you've said, you've said plenty things. What you've said is okay. Let's end it here. This is more like an aggressive statement. Is that okay? You are trying to control you are trying to apportion blame and all those comes under aggressive statements. Okay, good. So in therapeutic communication, we also have some principles like active listening, very key. Okay, you listen to the patient. Look at what statement will show that a nurse, you are listening to a patient. The statements like, "I understand, tell me more." So you are talking to a patient. "Oh, I understand your situation. Can you please tell me more?" It shows that you are actively listening. And sometimes pay attention to the example. Sometimes it's not just about the statement they are giving you. Sometimes so you should know examples or typical situations that explains these principles. Okay, so for example, you are talking to a patient and clarity and simplicity. That one is about using plain terms. This medicine would help you reduce pain. This medicine, so for example, we have these two statements. This medicine is an analgesic. This medicine would help reduce pain. Which one do you think is therapeutic? Which one do you think is therapeutic? This medicine is an analgesic. This medicine would help reduce your pain. Which one is therapeutic?
This
This
medicine will
medicine will help
reduce
Yes,
your
because
pain.
you realize that one is very simple and basic. It's very simple and clear as compared to using, that should tell you in therapeutic, you don't use, your nursing terminologies, your jargons, and try as much as possible to use very simple terms. Okay, that a patient will be able to understand. Okay, now we have empathy. Okay, I can see this diagnosis very frightening. Can we please have a more conversation about your situation? That shows you are showing empathy. You are interested in patient condition. That is, this statement expresses empathy. So sometimes they will present the statement to you. Then they are asking you which principle does it show, which they can present some statement to you, or they can ask you that, okay, as a nurse, which of the following statement below expresses that or indicate that the nurse is empathetic about the patient situations. Then they will give you some statements. So a statement like, "I can see this diagnosis frightening for you. Let's have a conversation. Okay. Now, in therapeutics, you should be respect and non-judgmental. You should be respectful and non-judgmental. Respect the belief of the patient. Okay, even if it's different. Understand that patients are always different. So you have to respect and be non-judgmental. Okay, irrespective of the patient background. Confidentiality is also something that is important. It's one of the therapeutic communication principles. Confidentiality. Learn how to keep patient information private. Okay, feedback. If patient tells you something, give a feedback. It's also very key in therapeutic communication. Timing and relevance. Avoid teaching when patient is sleepy. Okay, you are going to do you want to educate patients on condition at dawn, 1 a.m. Then you're going to wake patients up. Let's learn about hypertension. It should be timely and relevant. Okay, and you should teach patients things that are will be beneficial to their case. Okay, now therapeutic communication techniques. These 3 techniques are very important in therapeutic communication: summarizing, paraphrasing, and reflecting. Summarizing, paraphrasing, and reflecting. Very, very important in therapeutic communication. Summarizing, paraphrasing, and reflecting. These are very key techniques in therapeutic communication. So summarizing, so far you've said your pain worsens in the evening and improves after rest. You see, you summarize what the patient said. Okay, paraphrasing, you are saying the treatment makes you feel tired. Paraphrasing is like you are repeating what exactly patient said. You are paraphrasing and trying to put out a context that actually expresses what exactly the patient said. But reflecting, you seem worried about the surgery. Can you share what scares you most? You seem worried about the surgery. Can you share what scares you most? Okay, that is reflecting. Okay, you are trying to reflect on what is happening to the patient. That is reflecting. And these 3 techniques, they are very important in therapeutic communication. Okay, now mostly in general paper, they will assess you on these chromosomal abnormalities. Okay, chromosomal abnormalities and genetic disorders. Genetic disorders like sickle cell disease. So mostly with the chromosomal abnormalities, if they are doing, they would always do these 3: the Down syndrome, the Turner syndrome, and Klinefelter's syndrome. Okay, the Down syndrome, mostly chromosomal abnormalities. The problem is that there is errors in chromosome number or structure during the cell division. Okay, so these conditions, the underlying problem is that there are errors in the number of chromosomes supposed to be present or the structure of the chromosomes during the cell division. And sometimes these can affect the physical growth of the individual. It can affect how your ability to reproduce, fertility, and all these things. It can also affect the individual's intellectual development. Okay, a typical example is the first one is the Down syndrome. Another name for Down syndrome is trisomy 21. In Down syndrome, there is an extra chromosome 21 in Down syndrome. Okay, mostly the features we have there is intellectual disability, flat facial profile, upward slanting of the eyes, single palmar, crease, congenital heart defect, hypotonia, that is poor muscle tone. Okay, there is an extra chromosome 21. That is what happens in Down syndrome. Okay, how many chromosomes do we have? Yes, how many
46.
chromosomes? 46 chromosomes. We have 46 chromosomes, so meaning 23. In Down syndrome, what is happening is that there is an extra chromosome 21. Is that okay? And once there is an extra chromosome 21, that means that you should understand that is a genetic disorder. Okay, good. So there is what we call the presence of an extra copy of chromosome 21, and when that happens, that can affect the person's development. Okay, it can affect how the person develops. Okay, in terms of the intellectual ability of the person, in terms of even the health, how healthy the person will be, all that will be affected. That is what we call Down syndrome. Okay, we have the Turner syndrome. Turner syndrome, there is a missing one S chromosome. In fact, Turner syndrome occurs only in females. Okay, there is a missing one of the S chromosomes are missing. You know, in females we have XX. In Turner syndrome, we only have S. So instead of S, we have S0. So meaning one S chromosome is missing. Instead of the 10 being SS, it's only S. Okay, that is the Turner syndrome. So Turner syndrome, so sometimes they'll give you a scenario, then they are like a female. Once you see a female, be thinking about the Turner syndrome. Okay, once you see male, then they'll be talking about the Klinefelter syndrome. In Klinefelter syndrome, there is an extra S chromosome in males. There is an extra S chromosome in males. Okay, you know the males, we have SY. In Klinefelter syndrome, there is SSY instead of the SY. Now, sometimes they don't even write Klinefelter syndrome. They will just write SSY chromosome. It's the same. You have to understand the structure or the pattern of the chromosomes. Okay, so, and that should tell you Klinefelter syndrome can only occur. So if they tell you a chromosomal abnormality in female, sometimes they can give you a scenario. Then they are talking about a male with a chromosomal abnormality where there is an extra, then you know they are talking, it's more likely to be Klinefelter syndrome. Is that okay? So Klinefelter syndrome only occurs in males where there is an extra S chromosome. So we have SSY instead of S. Instead of the thing being SY, there is SSY. So the S chromosome is 2 instead of being 1. Is that okay? That is the Klinefelter syndrome. Okay, so extra S chromosome in males. Okay, so the features, we have tall height, we have small firm testes, infertility, gynecomastia, breast tissue development, especially in males, and then reduced facial body hair, okay, learning language, and then language difficulties. That is the Klinefelter syndrome. Mostly, this male is going to have female expressive or physically expressive body parts. Okay, so you are going to see the person with breast. Okay, the reason is because the person is having 2 S chromosomes. Okay, 2 S chromosomes, and sometimes it can affect the fertility of the person because these chromosomal abnormalities also comes with some hormonal imbalances. Okay, and that can affect the fertility of the individual. Okay, so we have Klinefelter syndrome, we have Turner syndrome, we have Down syndrome. Okay, Turner syndrome occurs in females. There is an absence of one of the S chromosomes in a female. That is Turner syndrome. There is an extra S chromosome in a male. That is Klinefelter syndrome. Okay, then the Down syndrome, trisomy 21. Okay, good. So that is it for the chromosomal abnormalities. Now, mostly the genetic disorder they ask questions on is the sickle cell disease. The sickle cell disease. Okay, the sickle cell disease. Now, with the sickle cell disease, you already know. I think sickle cell is something you already know from medicine. So I don't see it as an area you struggle if they should ask you a question on the sickle cell disease. So we can move on to psychiatric nursing quickly. Good. Now with psychiatric nursing, this is a branch of nursing care that focuses on people with mental problems. Okay, in psychiatric nursing, their scope is therapeutic communication, counseling, administering medication, crisis intervention, rehabilitation, psychoeducation, research and policy advocacy. Now, the causes of psychiatric conditions. Let's look at the causes of psychiatric conditions. So psychiatric conditions have this classification. The causes, it can be biological, it can be psychological, it can be social or environmental. Okay, for example, if a patient's depression, depression can be as a result of poverty. So many people are depressed because of poverty. It's not all that is because of genetic predisposition. It can be because of unemployment. Okay, even it can be because of unemployment. And some people are also having psychiatric conditions because of poor coping mechanisms. So the other time when I had a meeting with you, I was telling you, someone can get broken heart and end up with schizophrenia. Someone will get even a worse broken heart and will be walking freely, dancing, eating, learning normal. It won't affect the person in any way. It's about the coping mechanism. That one comes under psychological. Some people are psychological and emotionally fit. Nothing can break them down. Do you get it? So those one comes under poor coping mechanisms. Okay, and that is usually linked to anxiety and depression. There are some people, you can't scare them in any way. There is nothing that you do that will make them anxious. The time that they are even anxious, that's the time they are enjoying the best foods that they want. Okay, the coping mechanisms. Okay, and sometimes childhood abuse, all that comes under someone who have been raped before. Sometimes it can affect their personality. Okay, we have maladaptive personality. Okay, some people are antisocial. Some people have antisocial personality disorders. All that can contribute to some psychological conditions or mental health conditions. Okay, the social environmental causes of psychiatric conditions. Look at family conflict. Sometimes family conflicts can contribute to some. There are some people, they have certain moods, certain behaviors, and it's coming from family conflict. Sometimes broken relationships. There are some people who have certain beliefs, certain positions to certain things because of their background. Maybe they are coming from broken homes and all that. All that can affect a mental condition like substance abuse. It can be as a result of social environmental cause like peer pressure. Is that okay? But when we say biological factors or causes in psychiatric condition, we are looking at genetic predisposition. So for example, someone can suffer an infection and end up with a psychiatric condition like psychosis. Someone can suffer an infection and end up even experiencing hallucinations and delusions. Is that okay? Someone can suffer a brain injury and end up with dementia, like the Alzheimer's disease. Okay, someone can suffer a condition like Alzheimer's disease where the brain is degenerating and end up with a psychiatric condition like dementia. Do you get it? So that is it about the causes. So basically, psychiatric conditions can be classified under these three. The causes: biological cause, psychological cause, and social. And sometimes, listen, the reason why this is here in my slide is intentional. The reason is because sometimes the examiner is asking you a cause of a condition, like maybe schizophrenia, but the examiner will make an emphasis on social. Then the students jump straight away, then they will go and choose neurotransmitter imbalance. Meanwhile, the examiner is saying social. Is that okay? The examiner can sometimes, ask you a question on, let's say, anxiety. Okay, an anxiety disorder. Okay, then the examiner is saying psychological. If you are not careful, you can go and choose maybe neurotransmitter imbalance. You can go and choose infection, genetic predisposition. But the examiner was specific that psychological. So in such a situation, then you go and look for childhood trauma or childhood abuse. Okay, so you always have to be very careful with the choice that you make. Okay, now we have mood disorders. Okay, the mood disorders. Let's start with mood disorders. Okay, one of you should read, then I can do the explanation when it's necessary.
Mood disorders. Mood disorders are mental health conditions where a person's emotional state is disturbed for a prolonged period, affecting daily function. They may be caused by a combination of genetic factors, brain chemistry imbalances, that's neurotransmitters like serotonin and dopamine, stressful life events, chronic medical illness, or substance use.
Okay, that is fine. Okay, continue. You can continue.
Types 1. Depression, that's major depressive disorder, persistent sadness, hopelessness, loss of interest. Mania, abnormally elevated or irritable mood, overreactivity, overactivity, and poor judgment.
Okay, that's fine. Okay, continue. Continue. Now
Bipolar
explain.
disorder. Okay, say bipolar disorder, alternating episodes of mania and hypomania and depression. Signs and symptoms: depression, cardinal signs, persistent sadness, loss of interest or pleasure, that's anhedonia, and other signs include fatigue, poor concentration, sleep or appetite changes, suicidal thoughts, and low self-worth. Mania, cardinal sign, elevated or irritable mood. Others, decreased need for sleep, rapid speech, racing thoughts, impulsivity, grandiosity, and poor judgment. Bipolar disorder, alternating depressive and mania, alternating depressive and manic stroke, hypomanic episodes.
Okay. Okay. So all right. So these are the mood disorders. So the mood disorders, we have the depression. Depression is when someone is persistently sad, okay, feeling hopeless, loss of interest in activities. In fact, these are the key characteristics of depressed patients: persistent sadness, loss of interest in pleasurable activities. That is what we call anhedonia. When we say anhedonia, we are talking about someone losing interest in activities that previously they considered pleasurable. That is anhedonia. Okay, and it falls under the cardinal signs of depression. Okay, but apart from that, depressed patients may be weak. Okay, they may have poor concentration, they may sleep or appetite changes. Don't go and say that depressed patients will not sleep. Some people, when they are depressed, that is when they sleep. Some people, when they are depressed, that is when they eat. Other people too, when they are depressed, they are unable to sleep. When they are depressed, they are unable to eat. Okay, depressed patients may also have suicidal thoughts, low self-worth. Okay, these are the cardinal signs of depression. Okay, good. So when we say depression, that is what we mean. Okay, now mostly, sometimes you hear the examiner, you see the examiner using major depressive disorder. You see the examiner using major depressive disorder. It's the same thing. They are talking about depression. Okay, so major depressive disorder, the examiner is just talking about depression. Usually, with major depressive disorder, the symptoms are going to last for more than 2 weeks. Is that okay? These symptoms that we've mentioned, the persistent sadness, the loss of interest, the loss of interest in pleasurable activity, the symptoms are going to last for more than 2 weeks. Is that okay? Sometimes the examiner can use the word that we call dysthymia. Okay, the examiner can use the word dysthymia, more like persistent depressive disorder. All that comes under the depression. So the depression, we can have major depressive disorder, we can have persistent depressive disorder. Is that okay? And sometimes when we say dysthymia, it's the same thing, but you see, this cardinal signs is going to occur in someone, is going to last for, let's say, more than a year. So when we say the examiner gives you a scenario, pay attention. Or you started a psychiatry, because sometimes they can skew your question on the line of just psychiatric questions. So you have to be wild. Okay. So with a major depressive disorder, we are looking at greater than 2 weeks. the same symptoms that you are seeing, the same cardinal signs. So persistent sadness, loss of interest in pleasurable, poor concentration, either the person sleep or not, either there is good appetite or poor appetite, suicidal thought, low self-esteem for 2 weeks, then we are looking at major depressive disorder. If that is happening for more than a year, then we are looking at persistent depressive disorder. So if you see the examiner using the word dysthymia, they are still talking about depression. Be very alert. So if the examiner use the word dysthymia, dysthymia, the examiner is still talking about depression. Is that okay? And sometimes the examiner can use what we call the PMDD. The PMDD. When we say PMDD, we are looking at premenstrual dysphoric disorder. That is also depression. Don't get confused. They just use those words just to confuse you. So if you see the examiner using premenstrual dysphoric disorder, the examiner is still talking about depression. Premenstrual dysphoric disorder, the PMDD, the examiner is still talking about. Sometimes the examiner can use disruptive mood dysregulation disorder. It's the same thing. It's still depression. Okay, disruptive mood dysregulation disorder. The examiner is still talking about the same thing. They are still talking about the same depression. The same signs are the signs that will be there. Is that okay? So if you see the examiner using a statement like a woman with premenstrual dysphoric disorder, they are talking about depression. Disruptive mood dysregulation disorder, they are talking about depression. Is that okay? So it's just the same thing as depression. Now with the mania, we are looking at, when we say mania, on the other hand, mania, the focus is on what we call elevation. There is an elevated mood. We call it euphoria. Euphoria, the person is overly excited. Is that okay? That is mania aspect. And during the manic episode, the patient is in an irritable mood or elevated mood. Okay, mostly there is decreased need for sleep. There is rapid speech. There is racing thoughts, impulsivity, grandiosity, poor judgment. Is that okay? So for example, your licensing results have come. You get all the courses distinction. You become excited, euphoric, elevated. You become irritable. If you came to the school with car, you can walk to La Paz and now remember that you even came to the school with car and walk and come back and come and take the car home. Okay, because you're overly excited. Okay, you may not sleep. You'll be talking. Oh, then me, every exams are right. I'm going to get distinction. That is grandiosity. Is that okay? Good. So you are good, and all is because of the elevated mood, because of the euphoria. Is that okay? And these are the cardinal signs of mania. Rapid speech. They tend to talk a lot. They tend to talk. They will be talking too much. Is that okay? Good. All those things comes to. Sometimes the examiner would use what we call, will give you a scenario. Okay, the examiner will intentionally give you a scenario, like someone who is getting depressed, let's say during the winter period. What condition is that? What mood disorder is that? So you have a patient who during the winter period, then the person is getting depressed. What will come into your mind? Mostly those ones are what we call the seasonal affective disorders. The seasonal affective disorder. So we have some people that their mood episode is associated or linked to certain seasons. Mostly the winter depression. Okay, so when you are getting to winter, then their mood, their depressive episodes now tend to come. Either it's going to be manic or it's going to be depression. Okay, those ones comes under the seasonal affective disorders. Is that okay? Great. So basically that is it for the mood disorders. Okay, and then we have the bipolar disorder, where the patient can alternate between the mania, and then the depression. Sometimes the examiner can ask you, the examiner can use, let's say, bipolar 1, bipolar 2. Okay, when we say bipolar 1, okay, when we say bipolar 1, with a bipolar 1, what happens with bipolar 1 is that the patient would experience at least one manic episode. Okay, so occasionally the patient will experience one manic episode, and it wouldn't include a major depression. It will not include major depression. Okay, then we say patient is having bipolar 1. Okay, so the patient is going to experience just one manic episode. Is that okay? And it wouldn't include any. And so mostly, and that should tell you mostly the patient is elated as compared to being depressed. Then that one is more like a bipolar 1. If you say bipolar 2, that one patient there's going to be a balance. Patient is going to experience the hypomanic episode plus the major depression. Patient is going to experience mania, but then the mania is not so severe. Then the examiner is talking about the bipolar 2. Okay, with the bipolar 1, the patient is going to experience mania in whole, complete mania. Okay, a serious form of mania. But with the bipolar 2, there is a moderate form of mania. That is the hypomania. Okay, then the patient will experience a major depression. With the bipolar 1, patient will just experience the mania. Okay, the mania as a whole, and may not even experience major depression that much or depression that much. So once in a while, patients will experience the depression, but then patients, most of the episodes are manic episodes. That is bipolar 1. Let me keep it that way so that you understand it better. Okay, so with the bipolar 1, most of the time, most of the episodes are rather mania in bipolar 1. Okay, then once in a while, patients will experience the depression, the major depression. With bipolar 2, the manic episode is moderate. There is a hypomania, but then the patient experience major depression. The depression occurs, major depression. Okay, now then we have the other kind of bipolar we call the cyclothymic disorder. Okay, the cyclothymic disorder, usually what makes it different is that usually it's going to last for, so the patient can be in a certain episode for a long time. Okay, even though the patient will be in the patient will experience the hypomania and then the depressive symptom. But then when the depressive symptoms come, it can last for more than like a year. When the manic episode comes, it can also last for more than a year. Okay, then that one, the patient is experiencing the cyclothymic disorder. Okay, good. So with the cyclothymic disorder, the patient will swing between the hypomania and depressive episode. But then an episode can last for more than a year. Okay, then that one, they are talking about the cyclothymic disorder. Okay, so you just have to know the differences between the two. So we have the bipolar, we have the mania, we have depression. Bipolar, mania, and depression. Okay, so with bipolar, we have bipolar 1, bipolar 2, bipolar 3. The bipolar 3 is the cyclothymic disorder, where the patient is going to swing between hypomania and depression. But the hypomania episode can last for a year. The depressive episode, any of the episode that is occurring, can last for a year. Now, with the major depressive disorder, the bipolar 1, patient experiences one manic episode, and then the depressive episode is not so severe. Sometimes it may even take a long time before the depressive episode occurs. Then they are talking about bipolar 1. With bipolar 2, the manic episode is moderate. So that one, you say there is hypomania plus a major depressive disorder. That is the bipolar 2. Okay, good. Now, with the management of patients with depression. Now, when we finish all the psychiatric conditions, and I'll walk you through some of all the possible psychiatric medications that they can examine you on. We can have a detailed discussion on the psychiatric medications. Okay, now with the bipolar, with the mood disorders, these are the range of medications that they can manage. So in depression, they can give antidepressants, the selective serotonin reuptake inhibitors, the selective norepinephrine reuptake inhibitors, then the tricyclic antidepressants. These are the medicines that they give to a patient with depression. But mostly in all mood disorders, this medication is mostly used. Look, the other time I was telling you to pay attention to this. The lithium carbonate, this lithium. In fact, this is the common medication that is mostly given in most depressive patients. Okay, we call them the mood stabilizers. And most of the time in exams, if they are asking a medication, this is the medication you should be looking for. Mood stabilizers. I will advise you that at least, I will not mention it here, but at least pay attention to look at the side effects of the lithium carbonates, the side effects, okay, for this condition, the mood disorders. Pay attention to look at the side effects of this medication. Okay, it's also very important. It has side effects like nausea and vomiting, side effects like diarrhea, side effects like polydipsia, side effects like polyuria, side effects like weight gain. And if patient is taking this mood state, the lithium, mostly they are going to have this metallic taste in their mouth. If a patient is taking this lithium, they will have this metallic taste in their mouth. It's a common medication that they give to patients with mood disorders. If you are nursing a patient with these mood disorders, mania, bipolar, depression, it's very important you build therapeutic nurse-patient relationship. Provide ensure safety in patient environments because of the suicide rates. For example, the depression. Okay, promote adherence to medication, ensure regular sleep, a balanced diet, physical activity, provide education to the patient family, educate the family on the condition, make sure you put in place measures to prevent relapse, and then you provide community support resources. Okay, now eating disorders. With the eating disorders, we have the anorexia nervosa, we have bulimia nervosa, we have binge eating disorder. One of you should read the eating disorders.
Eating disorders. They are serious mental conditions marked by disturbed eating behaviors, distorted body image, and harmful effects on physical and psychological health. Types: anorexia nervosa, characterized by severe restriction of food intake and intense fear of weight gain. Bulimia nervosa, recurrent binge eating, followed by compensatory behaviors such as vomiting, laxative, and overexercise. Binge eating disorder, recurrent binge eating without purging. Signs and symptoms of the first one is anorexia nervosa, cardinal point signs, restrictive eating, very low body weight. Others, amenorrhea, lanungo hair, fatigue, intolerance to cold, distorted body image. Bulimia nervosa, cardinal signs, recurrent binge eating with compensatory purging. Others, normal or overweight body, dental erosion, swollen parotid gland, electrolyte imbalance, shame/guilt. Binge eating disorder, cardinal sign, recurrent binge eating. Can you close it for me? Recurrent binge episode without purging. Adversity, distress after eating, hypertension, and diabetes risk.
Okay, so usually what happens with anorexia nervosa is very simple. Anorexia nervosa severe restriction of food intake. The person fear to gain weight. The fear is that they don't want to gain weight. Okay, so they don't eat at all. That is anorexia nervosa. That is very simple. Now, with bulimia nervosa, okay, with bulimia nervosa, what happens is that there is a recurrent binge eating, then a compensatory action or behavior to get rid of the food. So the person eats a lot, then go and do exercise. The person eats, afterwards go and try to take a medicine to vomit. The person eats a lot, then afterwards the person is taking a medication to lose weight. That is bulimia nervosa. And recently I was watching a video on TikTok, a small boy saying that Ghana, we all have a problem. Yes, and it's true. So the person eats a lot of food, then takes an action to lose weight. That is bulimia nervosa. Okay, that is bulimia nervosa. Now, with the binge eating disorder, they say, oh, everything goes. Those people that they say everything goes, hey, let's eat, everything goes. They don't care whether they eat, they become obese. They don't care. They are the ones that they say, okay, everything goes. Okay, that is the difference between the three. So the anorexia nervosa is saying that I'm not eating, I don't want to. They fear to gain weight. In anorexia nervosa, it's a psychological problem. They don't want to gain, and sometimes these people are even slim. So meaning psychologically, they see themselves as obese already. And sometimes you look at them and they are even slimmer. Okay, so the anorexia nervosa, there is restrictive eating. They don't eat at all. Okay, and the fear is that they don't want to gain weight. Now with bulimia nervosa, they on the other hand, they eat a lot. Then they take an action to get rid of the energy, the food. Okay, so they've eaten, then they take a compensatory action or behavior to get rid of the food. So like vomiting, they can even self-induce. So sometimes they can bulimia nervosa, sometimes they can self-induce the vomiting. Okay, and as we tell you, people with bulimia nervosa is two things. In the options, be very careful. They can either be obese or have a normal weight. Okay, the binge eating, which of them do you think they will be obese? Which of them do you think they will be obese?
Eating disorder.
The binge eating. Which of them do you think they are likely to be anemic? Okay, which of them do you think they will be at risk of hypertension and why? Which of them do you think they will be at risk of hypertension and why? The binge eating disorder, because obesity, obesity is one of the risk factors for hypertension. Yes, the more you become obese, fat deposition in your blood vessels, atherosclerosis, this all contribute to hypertension. Is that okay? Good. Which of them do you think they can become malnourished?
Anorexia.
Yes, anorexia nervosa. Is that okay? Anorexia. Which of them do you think they can experience dental erosion? Dental erosion.
Bulimia nervosa.
Yes, bulimia nervosa. Bulimia nervosa. They can experience dental erosion. Is that because sometimes they do self-induced vomiting. Okay, and that can keep them at risk of dental. And bulimia nervosa, sometimes they experience guilt and shame. Bulimia nervosa and the binge eating disorders. Sometimes they look at themselves and they feel guilty because they eat too much. Then now they take, so sometimes they look at themselves, they feel guilty. Okay, good. So that is it about the eating disorders. Okay, with the treatments, sometimes some of them feel guilty, shameful. Sometimes it even makes them depressed. Is that okay? So sometimes they do the antidepressants like the fluoxetine, selective serotonin reuptake inhibitors, especially in the bulimia nervosa. They give the antidepressants. Sometimes too, especially, which of them would they give the appetite stabilizers?
Anorexia.
Yes, anorexia nervosa. Okay, and sometimes with the psychotherapy, they will do cognitive behavioral therapy, family-based therapy, or nutritional counseling for these patients. As part of the medical care, we should focus on monitoring the rate of the patient, make sure you correct dehydration, you make sure you pay attention to electrolyte imbalance, you treat all complications. Is that okay? So look at some of the signs of the eating disorder. See, they have mood swings sometimes, thinning of the hair, fatigue, fainting, especially in anorexia nervosa. You can faint, you become weak because you are not eating. Okay, unusual sweating. Okay, if you are not eating, don't you agree you can be hypoglycemia? Hypoglycemia. So in anorexia nervosa, hypoglycemia can even occur. You be sweating, you become weak. Okay, unexplained weight loss. All these are signs of bulimia nervosa. Okay, look at the other counterparts. Look at anorexia nervosa. You serve them with food, they'll go and throw the food away. Look at the picture over there. Look at this. They'll go and throw the food away. This lady has finished eating. No, she has taken banku with tilapia and she has sat on the bicycle. She will exercise the whole night after she has finished eating. Okay, look at this young man. Look, in a space of 15 minutes, the person is eating about 20 plates of banku. This young man, a short period of time, the person is eating a lot of foods. Okay, that would explain something like the binge eating disorder. A short period. And those who have binge eating disorder, if you are with them, every minute, every food that will pass, they will buy. Every food that will pass, they will buy. Every food that they will see, they will buy. The binge eating disorder. They don't care. Everything goes. Is that okay? That is a binge eating disorder. Now, delirium. Delirium. Okay, one of you should quickly read delirium for us.
Delirium, an acute fluctuating disturbance of consciousness, attention, and cognition that develops over a short period, that's hours to days, usually reversible if underlying cause is treated. Types: we have hyperactive delirium, characterized by agitation, restlessness, and hallucinations. Then the second type is hypoactive delirium, characterized by lethargy, reduced alertness, and withdrawal. The third type is mixed delirium, characterized by fluctuates between hyperactive and hypoactive. The causes: medical conditions, such as infections such as UTI, pneumonia, and sepsis, hypoxia, metabolic disturbances such as hypoglycemia, electrolyte imbalance, and dehydration, medical and substances such as drug toxicity, polypharmacy, alcohol or drug withdrawal, neurological causes, stroke, head injury, seizures, and dementia. Environmental factors: we have hospitalization, sensory deprivation, overload, surgery, and ICU stay. Now, the signs and symptoms, the cardinal signs. 1. Disturbance in attention, that's inability to focus, shift, or sustain. You have disturbance in awareness, that's reduced orientation to the environment. Other symptoms include sudden onset, fluctuating course, disorientation to time, place, and person, memory impairment, hallucinations, illusions, and paranoia. Altered sleep-wake cycle, that's day-night reversal.
Okay. All right. So that is fine. So delirium, with delirium, we are looking at an acute fluctuating disturbance of consciousness, attention, cognition that develops over a short period of say hours to days, usually reversible if the underlying cause is treated. Okay, now delirium, understand that one thing I want you to understand that is that, you know, delirium actually occurs in a lot of situations. Okay, with delirium, it occurs in a lot of conditions. You can have someone with meningitis who would be delirious. And I know you've next, delirium is about fluctuation in your level of consciousness. Okay, sometimes, for example, you sit in class for a long time, you don't eat, you are tired, you are stressed, you can be delirious for some time. That's why it can be reversible if the cause is treated. Okay, you can become hypoglycemic and become delirious. Okay, so delirium is about just that some people can experience delirium with psychotic symptoms like hallucinations. That is when we say then there is a hyperactive delirium. Is that okay? Someone can experience delirium, then the person is hypoactive. It's like the person is very weak. The person cannot talk. The person is withdrawn. The person don't want to eat. The person don't want to do anything. Someone to use delirium, the person can be hyperactive. Okay, so someone can experience delirium, the person is hyperactive. Another person can experience delirium, the person is hypoactive. Is that okay? That is delirium. Okay, good. Now, with the cardinal signs of delirium, look at the cardinal signs. See, disturbance in attention, disturbance in awareness. The person is disoriented. So they give you a question. They are talking about someone who is disoriented, someone who is unconscious, someone who is having memory impairment. You tell the person something, the person don't remember. You ask the person question, the person don't even know where he or she is. Mostly they are talking about delirium. Okay, hallucinations, altered sleep-wake cycles. This comes under more like hallucination. This should tell you that is hyperactive delirium. Is that okay? So that is basically about someone can have an infection like bacterial meningitis, and someone can have acid-base imbalance, electrolyte imbalance, and experience delirium. Someone can have a condition like drug toxicity. Is that okay? Someone can have a neurological condition like stroke. Is that okay? A neurological condition like stroke and experience delirium. Is that okay? Great. We have environmental factors like hospitalization, sensory deprivation. So that is just about delirium. Remember that delirium can occur in most conditions. Like someone can have a chronic or a terminal illness and become delirious. Someone can have an infection, electrolyte imbalance, and become delirious. Is that okay? Great. Let's look at the treatment. Our reader should continue.
Please, the treatment. Identify and treat underlying cause, whether it's infection, electrolyte imbalance, drug toxicity, metabolic disorder, substance withdrawal. Then we have supportive care, which include hydration, oxygenation, and nutrition. Some of the medications include low-dose antipsychotics such as haloperidol for severe agitation. And we have benzodiazepines if due to alcoholic or benzodiazepine withdrawal. Nursing care and interventions. 1. Ensure safety, thus prevent falls, injury, and remove hazards. 2. Provide a calm, well-lit environment, reduce sensory overload. 3. Reorient patient frequently to clocks, calendars, and familiar objects. Monitor vital signs, hydration, and labs. Promote normal sleep-wake cycle, and involve family for reassurance and orientation.
Okay. Okay, that is fine. That is fine. Of because of our time, let's look at a bit of public health. I think I'll come to, because I've met you on some of these areas. Okay, schizophrenia. We will look at it anyway. Schizophrenia, dementia, Alzheimer's disease, delusions, hallucinations, substance abuse, stress, anxiety disorders, the phobias. The phobias, we have specific types of phobias: agoraphobia, claustrophobia. Okay, what we will do is that the reader should quickly, I've engaged you on these areas before. The reader should quickly read all these areas. Then I would zoom directly into public health. There are some areas on public health that I have to touch on. So let's be fast.
Schizophrenia, a chronic psychiatric disorder involving the disturbances in thought, perception, emotions, and behavior, impairing daily function. Causes: genetic, genetic, higher risk in families with history of schizophrenia. Neurobiological, dopamine and glutamate imbalance, brain structure changes. Environmental, prenatal infections, malnutrition, birth complications. You have psychosocial, which includes stress and substance abuse, such as cannabis and drugs. Types of schizophrenia: paranoid, characterized by delusions and hallucinations; disorganized, characterized by disorganized speech, behavior, or plot affect; catatonic, characterized by motor rigidity, mutism, and echolalia; undifferentiated or residual schizophrenia, characterized by mixed or residual features. Signs and symptoms: cardinal signs. We have the positive symptoms, which is delusions, hallucination, especially auditory and disorganized behavior. Negative symptoms such as flat affect, apathy, social withdrawal, and lack of motivation. Other symptoms include cognition impairment, poor concentration, disturbed sleep, and poor insight.
Okay, let's move on to the next.
Treatment. Pharmacological treatment. The first one is antipsychotics. So the first generation, we have haloperidol and chlorpromazine. Second generation, risperidone, olanzapine, and clozapine. Psychological and social. We also have CBT, cognitive behavioral therapy, family therapy, social or occupational rehabilitation, and community support. Nursing care and intervention. 1. Ensure safety, risks of self-harm or violence during psychosis. Build therapeutic, trusting relationship. 3. Monitor and administer and monitor medications. Watch for extrapyramidal side effects such as tardive dyskinesia. Dyskinesia. Provide calm, structured environment. Encourage self-care and social interaction gradually. Reassure and reorient during hallucinations or delusions without confrontation. Educate patients and family on illness, medication adherence, and relapse prevention.
Okay, that is fine.
Dementia, a chronic progressive decline in memory, thinking, behavior, and ability to perform daily activities due to brain disease or damage. Unlike delirium, dementia develops gradually and is usually irreversible. Causes: neurodegenerative disease such as the Alzheimer's, Parkinson's, Lewy body dementia, and frontotemporal dementia. We have vascular causes such as repeated strokes or reduced blood supply to the brain. Other factors include head injury, chronic alcoholism, infections such as HIV and syphilis. Types of dementia. We have the Alzheimer's disease, which is characterized by gradual memory loss, confusion, and language difficulties. We have the vascular dementia, which is characterized by stepwise decline, linked to strokes or vascular dementia. We also have the Lewy body dementia, which is characterized by visual hallucination, movement problems, and fluctuating alertness. We have the frontotemporal dementia, caused by early personality or behavioral changes and language problems. Signs and symptoms include the cardinal signs are progressive memory loss, impaired reasoning or judgment, personality or behavioral changes. You may have other symptoms like disorientation to time, place, and person, difficulty communicating or finding words, poor concentration and problem solving, mood swings, agitation, hallucination in some types. Then we have loss of ability to perform daily tasks such as self-care, hygiene, and finances.
Okay, it's okay. That is fine. It's okay. That is fine. Okay, so with the public health, okay, you pay attention to monkeypox. Okay, you pay attention to monkeypox. Now, monkeypox, as you know, is a viral zoonotic disease. You know, it's caused by the monkeypox virus, or sometimes you can say the otopus virus. Those viruses are related to the smallpox virus. Okay, that is the monkeypox. You know, the mode of transmission is from animals to human. That is why we say it's a viral zoonotic disease. So the mode of transmission is from what? Animal to human or human to human. It has two modes of transmissions. Please remember, it has two modes of transmission: animals to humans and humans to humans. That is why we say it's a viral zoonotic disease. Okay, so in animals to humans, it could be from the bite of the infected animal. It could be from a scratch. It could be from you consuming bush meat. Is that okay? When you consume a bush meat, a meat that is infected, an animal that is infected, the meat. It could be from human to human, like when you come in direct contact with the skin lesions of an infected person, you can get it. Body fluids of an infected person, respiratory droplets of the infected person, contaminated materials of the infected person. It could also be as a result of sexual contact. What is the incubation period for monkeypox? What is the incubation period? 6 to 13 days. Okay, 6 to 13 days. That is the incubation period. Now, with the clinical features, okay, with the clinical features, we have fever, we have headache, we have the back pain. Okay, one very important sign in monkeypox is lymphadenopathy. Please remember, one very cardinal feature of monkeypox is lymphadenopathy. It's a very important sign in monkeypox, lymphadenopathy. Apart from that, the rash is also there. Okay, the rash. If the examiner asks you that, okay, what signs do you expect in the prodromal period? The prodromal period, the signs there are the fever, the headache, the muscle ache, the back pain, the lymphadenopathy. They are then the rash period. The prodromal period is a period where we don't expect the rash. So the rash period is where there is the macules, the papules, the vesicles. That is when the signs that are similar to the smallpox would appear. And another key thing you need to notice that if they ask you where the rash often begins, for monkeypox, the rash usually starts on the face. Yellow fever, where does the rash start from? In yellow fever, the rash, where does it start from? The rose spots, where does it start from? On the trunk. Okay, in yellow fever, it starts on the trunk. But in monkeypox, the rash usually begins from the face. Is that okay? It starts from the face and it spreads to the extremities. Okay, in monkeypox. So in monkeypox, the rash usually starts from the face. Then it begins to spread to the extremities, including the patient's palms, the patient's soles. Okay. One key complication of this monkeypox is if a patient is having monkeypox, usually they can have conditions like pneumonia, encephalitis, and even eye infections. Is that okay? Good. With the preventive measures, you have to, as a nurse, you should make use of your PPEs and avoid contact with animals, especially in very contagious areas that the condition is spreading. Okay, good. So basically, that is it about the monkeypox. Understand that it's a viral zoonotic disease caused by the monkeypox virus. We can have the animal to human transmission, human to human transmission, like respiratory droplets, contaminated material, sexual transmissions. That is the monkeypox. With the yellow fever, okay, with the yellow fever, yellow fever is caused by the yellow fever virus, or how we call the flavivirus. Okay, so yellow fever is caused by the yellow fever virus or the flavivirus. That is the yellow fever virus. What's the incubation period for yellow fever? 3 to 6 days. 3 to 6 days. What's the incubation period for monkeypox? 6 to 13 days. 6 to 13 days. Incubation period for yellow fever, 3 to 6 days. And you remember yellow fever has some clinical stages. I don't know if you remember, we discussed it when we were looking at medicine. The week 1, week 2, week 3, week 4. Okay, week 1 is where we have the step ladder fever, if you remember, the low-grade fever, where we have the headache, the body pain, the bradycardia, and then if they ask you that if a patient is having yellow fever, okay, at what point will the blood test be positive? Usually, if a patient is in the first week, usually the best test to do, the best diagnostic test to confirm the diagnosis is the blood culture. Within the first week, the week 1, blood culture is likely to be positive if you do a culture. So you are likely to isolate the organism. So for yellow fever, then we have the second week. So with the second week, that is where the body temperature becomes so high, and patients will experience abdominal pain, diarrhea, the rose spots. The rose spots usually appears on the trunk. One cardinal sign. What is the main cardinal sign that I mentioned in monkeypox? Lymphadenopathy. If you come to yellow fever, one very cardinal sign that we talk about is enlarged liver and spleen, hepatosplenomegaly. Hepatosplenomegaly. In monkeypox, we mentioned lymphadenopathy. It's a cardinal sign in monkeypox, remember. But when you come to yellow fever, hepatosplenomegaly is there. Enlargement of the liver and enlargement of the spleen. In the second week, patients can be delirious. Okay. Now, in the second week, if you want to do a test, you can do the Widal test in the second week. Widal test is usually positive. So if a patient is in the first week, please, if the examiner tells you scenario, patient is in the first week, don't go and choose Widal test. You'll be marked wrong. In the first week, if they tell you patient is in the first week, you have to rather consider blood culture, not the Widal test. Widal test will be negative in the second week. Sorry, Widal test will be negative in the first week. Even though the best test to do in this condition is the Widal test, but Widal test will be negative in the first week. That is why in the first week, they will usually diagnose with a blood culture. But if it is the second week, at that time, the Widal test will be positive. Remember that. Now, with the third week is when the condition has become so severe, toxicity has set in. So in the third week, expect signs like intestinal perforations, okay, signs like anemia, intestinal hemorrhage. All those things occurs in the third week. In the fourth week, during that time, the temperature is now beginning to fall gradually. The fourth week is like a recovery period. The fourth week is like a recovery period or a recovery phase. That is when the temperature is beginning to reduce more. Okay, that is what we call the fourth week. So in the fourth week, it's like recovery. The patient is now recovering. The third week is when there are serious complications, toxic complications. There can be septicemia. There can even be myocarditis. There can be pneumonia. There can be encephalopathy. There can be intestinal perforations. There can be intestinal hemorrhage. That occurs in the third week. In the second week is where we have the rose spots appearing. The rose spots, it appears on what? On the trunk. Okay. Then in the the second week is where we have the serious sign. The one of the cardinal signs, hepatosplenomegaly, the enlarged liver, and then the enlarged spleen. And also we have something we call typhoid state. They can tell you that, okay, if a patient is having typhoid fever, they can experience what we call typhoid state. What does it mean? Which week does it occur? The typhoid state is when there is confusion, there is metering, there is stupor. The patient can become unconscious, sometimes even experience seizures. It occurs in the second week. Be alert. Okay, good. So remember that with typhoid fever, they do blood culture and whiteout test. The best test to do is the whiteout test, but the whiteout test will not be positive in the first week. So they usually do use the blood culture with the diagnosis. Then in the second week, they'll do the whiteout test. Whiteout test will be positive in the second week. Okay, whiteout test is negative mostly in the first week. Is that okay? So with the first week, that is where we have the fever, low-grade fever, headache, malaise, bradycardia, positive blood culture. All that occurs in the first week. Positive whiteout test should be expected in the second week. In the second week is where the temperature peaks, 39 to 40 degrees Celsius. That is when the rose spots appear. That is where we have one of the key signs. And that is the week that we even have the typhoid states or the typhoid syndrome, where there can be confusion, where there can be stupor, unconsciousness, delirium, all that occur in the second week. In the third week is toxicity period. You can call it toxicity, state of toxicity. That is where there can be perforations. That is where there can be some complications like hemorrhage, anemia. That is where there can be myocarditis, pneumonia. All that occur in the third week. Is that okay? So that is just about typhoid fever and then monkeypox. Okay. Now, no certain terminologies when it comes to disease pattern or epidemiology. Now, with disease pattern, terms like sporadic, when we say sporadic, you should know what it means. Okay. So, for example, if you say, let's say, if you take a condition like, let's say, tetanus, okay, then today you hear that, okay, tetanus, one case of tetanus in, let's say, Eastern region. Tomorrow you hear, let's say, one case of tetanus in, let's say, Ashanti region. Maybe in 2 months' time, another one case. Then we say it's sporadic. Okay, sporadic simply means it occurs occasionally and irregular. So let's say tetanus case, one case in, let's say, Ashanti region. Then in 4 months' time, let's say two cases of, let's say, tetanus in Eastern region. You see, the pattern is not regular. That is what we call sporadic in epidemiology. The pattern is not a regular, it's not following a regular pattern. Okay, so in epidemiology, we call that sporadic. The spread of the disease is sporadic, or the pattern of the disease is sporadic. So if the pattern of a disease is not so regular, it's not following a regular pattern, we say it is sporadic. But then see, let's say every day in Accra, we are recording 5 cases of a disease. It's not sporadic. Sporadic, let's say today Accra 1. It will not occur again 4 months' time, then maybe 2 cases. You see, even the frequency is not even regular. That is sporadic in epidemiology. Okay, then we have what we call endemic. Endemic is when a disease is present in a geographical area or a population. It's always present, constant presence of a disease. For example, malaria is endemic in Ghana. Malaria is endemic in Ghana. It's constantly present in Ghana. It's within our population. It's always there. Every day you have someone with malaria. So it's endemic. So when we say a disease is endemic, it is constantly present in a particular geographical area. Then we say it's endemic. Is that okay? For example, you can even say a disease like malaria is endemic in sub-Saharan Africa. It's always present. there is always someone who have malaria. That makes it endemic. Then we have the other one we call the epidemic. Okay, epidemic. When we say epidemic is when there is an occurrence of a disease greater than the expected number in a community. So, for example, do you know that cholera is something that occurs? Occasionally, we have, for example, like Accra, if you are working in a polyclinic, occasionally people can come with cholera. But if the number that we, for example, let's say in a month, let's say in a month, 5 people usually get cholera, report to hospitals or health facilities in Ghana with malaria. Then in a month, 1 million cases of the same malaria case. Then malaria has now become an epidemic. It is now an outbreak. Okay, so you can have a condition that is endemic, meaning the condition is constantly present in a particular community, but it can become an epidemic condition. So when we say a condition is epidemic is when the expected numbers that we want to see in a particular community, we are suddenly getting numbers that we don't expect. Then we say it is now an epidemic. Another word they can use for an epidemic is an outbreak. Okay, so for example, let's say in a community like, let's say Accra, let's say every week, let's say typhoid fever cases is 5 at Kolebu Polyclinic. Then let's say Kolebu Polyclinic, then suddenly 200 cases report. Then that is considered as an epidemic or an outbreak. Okay, so epidemic is when the number of cases of a particular disease that is expected in a region, we are exceeding that expected number of cases. Then we say there is an epidemic. Epidemic is the same as, is similar to outbreak. It's the same thing. Okay, so if let's say malaria, for example, malaria is something that if you come to, for example, Pentecost University, CAF University, whatever, constantly malaria is there. So we can say malaria is endemic in Pentecost University. Malaria is endemic in CAF University. Malaria is endemic in Cape Coast University. Malaria is endemic in Accra. Malaria is endemic in Ghana, meaning all the time we have people with malaria. Now, let's say a facility like Kolebu, every week 5 people report with malaria. Then one day they go to work, 300 people have reported with malaria. That one is an epidemic. It's an outbreak. Then now it's an outbreak because the expected number, outbreak is when the expected number of cases that we expect in a region, provided even whether or not there is it is an endemic area or whatever, the expected number of cases we are expecting, we exceed the number. Or outbreak is when we are getting numbers that are beyond control. That is when we say there is an epidemic. Anytime you see the word epidemic, we are talking about an outbreak. We are getting numbers that are beyond control, or we are getting numbers that we are not expecting to record in a day or in a particular period. Okay, that is when we say there is an epidemic. So anytime you see epidemic, see it as outbreak. Epidemic, outbreak. Epidemic, outbreak. Endemic meaning constant. Endemic means constant. It's always there. You can use yourself as an example. I'm an endemic student, meaning I'm always in class. I'm always going to class. Endemic. Epidemic meaning you are going to class more than it is expected, meaning an outbreak. Okay, that's the difference. Then we have pandemic. Pandemic is when the disease spread across countries and continents. So, for example, let's say monkeypox, it starts in Ghana, then it spreads to, let's say, a condition that became pandemic was the COVID-19. Okay, something starts in China, then by the time you hear it's in another country, it's in Europe. By the time you hear it's in Africa, then it has become pandemic. Pandemic is when a disease is spreading from one country to another. That is pandemic. Is that okay? Good. So basically these 4 terms you have to understand their meanings and how they apply. Now, if you come to Ghana, we have the Ghana National Immunization Schedule. Okay, if you come to Ghana, we have the National Immunization Schedule. The National Immunization Schedule is more like a document that is adopted from the WHO. Okay, it gives an idea on the routine expanded program on immunization. More like it gives you the schedule on how immunization is supposed to be done. Okay, per that schedule, at birth, okay, we have certain vaccines that you are supposed to be given. For example, at birth, a vaccine like the Bacillus Galmet urine, the BCG vaccine for tuberculosis prevention, is supposed to be given at birth. Okay, mostly at birth, we have 3 vaccines that are given. So at birth, we have the BCG vaccine, we have the oral polio vaccine, okay, and then we have the hepatitis B vaccine. So mostly the vaccines that are given at birth. So they can ask you that which of the following vaccines are usually given at birth, except, okay, at birth, usually we have the BCG vaccine, the oral polio vaccine, the Hep B vaccine. These are the vaccines that are given at birth. Okay. Now, between the 6th, 10th, and 14th week after birth, 5th, 6th, 10th, and 14th weeks, usually we have these vaccines. We have the pentavalent, which is the DPT hep. They are the pentavalent vaccines. Okay. We have the oral polio vaccines, the continuum dose, because at birth, you've taken 1 dose at birth. The continuous dose may be given between 6, 10, and 14 weeks. Okay. We have the pneumococcal conjugate vaccine, pneumococcal vaccine, the PCV vaccine. Okay. Then we have the rotavirus vaccine, at least 2 doses for the rotavirus vaccine. And then we have the inactivated polio vaccine on the 14th weeks. Okay, so between 6th, 10th, and 14th weeks, they give the pentavalent vaccine, the DPT hep, the oral polio vaccine, the pneumococcal conjugate vaccine, and then the rotavirus vaccine, as well as the polio vaccine that is given on the 14th weeks. Now, usually 9 months after birth, 9 months after birth, usually the vaccines that are given are the measles, rubella. Okay, the second dose of the measles, rubella vaccine is given in fact, the first dose is given on the 9th month, and then the second dose is given on the 18th month. So the 9th month, they give the measles, rubella vaccine, the first dose. Then yellow fever, the single dose vaccine. You know, yellow fever is a single dose vaccine. So if they ask you, one of the following vaccine is a single dose vaccine, one of the answers you should be looking for is the yellow fever vaccine. And they give it on the 9th month. Okay. Now on the 18th month, they give the measles vaccine, the second dose. Do you know they give you the measles vaccine, the first dose, they give it on the 9th month. Okay. The second dose, they give it on the 18th month. Then another vaccine that is also a single dose is the meningococcal vaccine. The meningococcal vaccine. That one too is a single dose vaccine like the yellow fever vaccine. Yellow fever vaccine is single dose. Meningococcal vaccine is also a single dose vaccine. Is that okay? Then for adolescents, at any point within the adolescent period, they can give the tetanus, diphtheria. Okay. The booster, some people don't even take it out until maybe they are going to work in a certain facility. Then the facility may even request and they may have to give them. Is that okay? Even hepatitis, sometimes some facilities may give, even some schools may sometimes do those vaccines. So tetanus, diphtheria, the booster every 10 years for women of childbearing age. Okay, so these are the vaccines that in fact, the vaccines, you should even go ahead to even know their routes of administration. For example, if you take the BCG, the hepatitis B, mostly the oral polio vaccine. What is the route for the oral polio vaccine?
Oral.
Oral. Okay. How about BCG?
Intradermal right arm.
Yes, BCG, intradermal right arm. Okay. Usual. So at least for vaccine like BCG, you should know the routes of administration. How about pentavalent? How about the pentavalent?
It's on the left side.
The left side.
Intramuscular.
Okay. Okay, that is fine. That is fine. And then the yellow fever vaccines are also injectables. Okay, so at least you should know. And sometimes you should even have an idea of the side effects. So, for example, the BCG, for example, scars can occur, a bump can occur. Some of them comes with side effects like fever, swelling, sometimes rash. Okay, like the yellow fever vaccine, for example, sometimes a rash may be there, fever may occur. Sometimes headache may even be present, especially with the yellow fever vaccine. Okay, so with the yellow fever vaccine, rash, fever, and headache is a cardinal side effect that you have to take note for the yellow fever vaccine. Okay, so these are key things that you have to know regarding the immunization schedule. Now, we have something we call epidemiological triad. We have something in public health we call epidemiological triad. Okay, if we say epidemiological triad, we are looking at how certain factors interact for a disease to occur. Okay, epidemiological triad actually includes 3 factors. We have the host, we have agents, and the environment. We have the host, we have agents, and the environment. In epidemiological triad, we are looking at how these 3 factors, how they interact for a disease to occur. Okay, so for example, host, agents, environment. How do they interact for a disease to occur? That concept is what we call the epidemiological triad. Okay, so for example, if you look at a host, we are looking at a person or a population. A host is not just a person. A host is a person or a population. Okay, so if you take a host, there are certain factors in the host that can cause a disease. For example, if you take a host like a person, there are certain diseases that if the person ages or grows, the person becomes at risk of developing those conditions. Okay, so that is the host factors. If we can have certain disease, so for example, Klinefelter's syndrome, you know, the host factor, it will only occur in a female. It can't occur in a male. Okay, so there are certain diseases that is such that it can only occur or be dependent on the host. Is that okay? Now, if you have a particular communicable disease, the host will play a factor in the sense that if the host immune system is very weak, the disease would occur. That is what we mean by epidemiological, how these factors, and in epidemiological triad, we are looking at 3 factors: the host, the agent, and the environment. These 3 factors are the 3 factors that have to be at play for a disease to develop or for a disease to spread. So, for example, if you look at the agent is where we are looking at the causes of the disease. Okay, so a disease is not only the agent can be there, but someone can have a strong immune system. When COVID-19 came, a lot of people didn't get the condition. Okay, even though the agent was in the environment, the agent was there. But a lot of people, the agent is about the organism. Okay, the agent, for agents of diseases, we can have chemical agents, we can have biological agents, we can have physical agents. So if you take agents of diseases, we can have physical agents, we can have chemical agents, we can have biological agents. Biological agents like bacteria, biological agents like viruses, biological agents like parasites. So if the examiner asks you, okay, in epidemiological triad, one of the following is a biological agent of a disease. Biological agents are the organisms like bacteria, viruses, parasites. Like Mycobacterium tuberculosis, which is a bacteria. Those are biological agents. When we say chemical agents, do you know it's not only bacteria and organisms that causes disease? We can have chemical agents like toxins. Someone can take a poison and get a disease. Someone can take a pesticide and get a disease. Okay, someone can take any medication and end up getting a disease from the side effects. Okay, those ones are chemical agents. Then we have the physical agents. Someone can sit in sun and get cancer. Okay, someone can be exposed to a certain physical factor and get. Someone can be involved in an accident and get fracture. That is a physical agent. Okay, so with the agents, the agents are basically what causes disease in a population. So when we say an agent, is something that causes disease. It could be a bacteria, it could be virus, that is the biological. It could be a chemical. So if the examiner asks you, okay, which of the following is a physical agent in epidemiological triad, or the following, one of the following is not a physical agent in epidemiology, then they will write radiation, trauma, and bacteria. What will be your answer? Radiation, trauma, bacteria. What will be your answer? Yes, what will be your answer? Okay, so if the examiner asks you that one of the following is not a physical agent in an epidemiological triad, then the examiner gives you radiation, trauma, bacteria. What will be your answer? Yes.
Say bacteria.
Okay, that is correct, because bacteria is a biological agent. Okay, which of the following is a chemical agent in epidemiological triad? Pesticides, heat, virus.
Pesticide.
Yes,
Pesticide.
pesticides. Okay, now when we come to the environmental factors in the epidemiological triad, environmental factors are like factors within the environment that can contribute to a disease. With the environmental factors, we have physical environment, we have biological environment, and then we have the socioeconomic environment. Okay, that's what we call the environment. Okay, do you know that there are some diseases, like for example, if you take the monkeypox virus, for example, you know the monkeypox virus, because it's a viral zoonotic disease, you need that animal in the environment to facilitate with the disease transmission. Okay, so the environmental factors, we also have biological under the environmental factors. Okay, for example, if you take a condition like malaria, even though the parasite, the host itself, the organism itself, the agent itself is the Plasmodium parasite. But then the agent needs to go through the biological factor in the environment, which is the vector. Okay, like the mosquito, the flies, before the disease, before the host will be able to reach the host. Okay, before the agent will be able to reach the host. Okay, and that is that falls under the environment. Okay, so under the environment, we have the physical factors, we have the biological factors, and we have the socioeconomic factors. Okay, and this is what we call epidemiological triad. So sometimes in the exam, they can tell you one of the following is not part of the epidemiological triad. The epidemiological triad, there are three: host, agent, and environment. The host, the agent, and the environment. That is what we call the epidemiological triad. The host, the agent, and the environment. Okay, if we say a vector is more like a living organism that transmits a disease. In public health, when we say a vector, it's a living organism that transmits a disease. And usually in epidemiological triad, the vector is under the environment. Vector is not under the agent. The agent is the causative organism, like the bacteria, the virus. Okay, if it is any other condition, it could be a chemical agent, it could be a physical agent. Okay, so if you say malaria, mosquito is not an agent. Mosquito is a vector. Vector is under the environmental factor. The agent itself is the plasmodium parasite. Plasmodium, the parasite, the plasmodium parasite, that is the agent. But the mosquito is the vector. The vector is under the environment. The vector is under the biological factor in the environment. Okay, you have to understand the difference between the two. So when we say a vector, is someone asking a question? When we say a vector is a living organism that transmits a disease. A vector is not an agent. Okay, if you say an agent is a factor that causes the disease directly. Do you get it? So sometimes the agent has to pass through the vector before it reaches the host. Do you get it? And remember that the vector is also in the environment. Okay, the vector is also in the environment. And sometimes the agents have to pass through the vector before you reach the host. Is that okay? Okay, so that is it about. When we say a reservoir is where the agent normally lives and multiply. That is a reservoir. Okay, so a particular agent like a bacteria can have a reservoir, can have an animal as a reservoir. Is that okay? Good. So that is it for the epidemiological triad. Okay, the next thing that I would talk about, I'm sure that may be the last area that we will touch on, is what we call the types of immunity in public health. Okay, the types of immunity in public health. Now, in public health, we have mainly 3 types of immunity that you have to understand in the general paper. You have about 3 types of immunity that you have to understand. We have the innate immunity. We have acquired immunity, and we have community or herd immunity. Okay, we have 3 broad classifications of immunity. Innate immunity. Sometimes some books, they call it the natural or inborn immunity. Okay, so we have innate immunity, or you can call it the natural or inborn immunity. Then we have acquired immunity. Okay, then we have the community or herd immunity. When we say innate immunity or natural immunity, innate immunity is more about, for example, mostly innate immunity is present at birth. Is that okay? You know, innate immunity even includes your skin and mucous membrane acting as barriers. All forms part of your innate immunity. For example, in your stomach, we have the hydrochloric acid, which kills ingested pathogens. All falls under innate immunity or natural or inborn immunity. For example, every human being, you have the phagocytes, which are the natural killers. All forms under innate immunity. So innate immunity or natural immunity, they include like your skin barrier, your stomach hydrochloric acid, you having phagocytes, okay? All those falls under innate or natural immunity. Now, when we say acquired immunity, we can have what we call active immunity, and we can have passive immunity. We have passive immunity and active immunity. Now, when we say acquired immunity in general, acquired immunity develops after birth. Okay, and acquired immunity is specific to a type of pathogen. So, for example, when you are born, okay, you know you don't have acquired immunity for chickenpox, but when you get chickenpox, then you develop an immunity against chickenpox. So that is an acquired immunity. So, and that is the reason why you can have an active immunity and then active acquired immunity and passive acquired immunity. So when we say an acquired immunity, but the natural immunity, the moment you are born, every human being, the moment you are born, your stomach hydrochloric acid is inside. Am I lying? It's there. So it's a natural immunity. It's an innate. You were born with it. So when we say innate immunity, you are born with it. Every human being, you are born with phagocytes in your blood. Phagocytosis. for phagocytosis, they are in your blood already when you are born. So it's natural. You are born with it. You don't have to get a disease before you get phagocytic cells. Okay, so it's natural, it's innate. Your skin, every human being, you have a skin. When right from birth, you have hydrochloric acid in your stomach. It's natural, it's innate. You don't have to get a disease before your hydrochloric acids will form in your stomach. So it's natural. Those ones are what we call the innate immunity. But when we say acquired immunity, with acquired immunity, it develops after birth. Is that okay? And it is specific. It develops specific following a certain exposure to a certain disease. So, for example, if you take the acquired immunity, we can have active acquired immunity. For example, usually you see your body produces its own antibody after you are exposed to a certain antigen. An antigen usually represents the organism, a causative organism. So, for example, we can have the active immunity. We can have types. We have the natural active immunity. So, for example, you've gotten a condition like an infection like measles. Then your body develops immunity against the measles. Is that okay? That is a natural active immunity. And we can also have an artificial active immunity. For example, we can intentionally create a vaccine that looks more like the organism, then we inject it in you. So the immunity that we get from the vaccines that we take, they are acquired active immunity. So if the examiner tells you that, okay, a child has been given, let's say, measles vaccine, and the child gets immunity, that immunity is an artificial acquired immunity. Okay, that immunity is an artificial active immunity. An artificial active immunity. Why is it an artificial active immunity? We've given you a vaccine. We've prepared the vaccine to have the similar structure like the organism, and they've injected it in you so that your body will form antibodies against it. You are not having those antibodies. But then, you didn't go and get the measles. You get it. You didn't get the measles naturally. We have injected something that have the structure like the measles in your body so that your body will form the antibodies for it. So that one is an artificial acquired immunity. It's artificial. So if I give you an example, that's okay. A child got measles naturally. The child was infected with measles. And after the infection, the child's body have developed an immunity or an antibody against the condition. What type of immunity is that? What option will you be looking for? So let's say a child has actually gotten measles, and after the condition, the child has developed antibodies against it. What type of immunity is that?
Naturally acquired immunity.
Good. That is naturally acquired immunity. Okay. The other example is, okay, we've prepared measles chemical vaccine in the lab. Then we've injected it in a child, and the child has gotten immunity. That one is artificial acquired immunity. Okay, that one is artificial. That one wasn't natural. It's artificially acquired. Okay, that one is also an acquired active immunity, but that one is artificial. Okay, so with the acquired immunity, we have active. Okay, we have active. The active means that you are coming directly in contact with the organism, but that one, it can be natural or it can be artificial. You can come in contact with the organism directly. That one is naturally active. What is making it active is you are getting the antibodies from exposure to the condition, so that makes it active. But that's coming into contact. It can be we prepare the organism structure in the lab and inject in you as a vaccine. So if we injected in you as a vaccine, that one is artificially active immunity, but it's still acquired. If you came into contact with the organism naturally, that one is natural active immunity. You get it? So get the difference. Then we have the passive. Okay. Do you know the passive? The passive one, let me show you how the passive one looks like. is very simple. The passive one, let me use example, Betty. You see, Betty, when they gave birth to you, okay, I will explain from the active, then I'll take you to passive. This is the last thing that we do. Now, let's say use someone like Betty, for example. When Betty is born, when they give birth to you, you already have a skin. You already have hydrochloric acid. You already have white blood cells. Those ones are innate immunity. You were born with them. You didn't come to this earth before you got it. You were born with them. So those ones, they are natural. Those ones, they are the innate immunity or inborn immunity. Now, when Betty, after birth, for example, after birth, let's assume that after birth, then now you come in contact with, let's say, a measles virus. Then your body, you came in contact, you had the disease naturally. You actually came in contact with the organism naturally, and you've passed through the disease. Your body have formed antibodies against it. That one is it's a natural active acquired immunity. It's natural active acquired immunity. Now, let's say that the same Betty, this time you didn't get the measles naturally. You went to public health facility. They've given you a medicine that has been prepared in the lab, which have the chemical structure like the measles organism. And when your body saw that your body has formed antibodies for measles, that one is an artificial active acquired immunity. Now, Betty will grow and give birth. Betty, when you give birth, remember that your body has formed that antibody in you. When you give birth, you pass it to your child. Okay, so for example, Betty, if you had the measles naturally, let's say Betty had the measles organism naturally, she came in contact with measles disease naturally. She has formed antibodies. That antibodies that she formed is a naturally active acquired immunity. She have it. If she gives birth, she will pass that naturally acquired one to the child. The naturally acquired one that she acquired, she will pass it to the child. It will now become a passive natural immunity for the child. But if Betty didn't meet the measles organism naturally, but she took the injection, the vaccination, and she formed the antibodies, when she passed it to the child, it's now a passive immunity for the child. It's an artificial passive immunity for the child. Artificial passive immunity for the child. She will pass it on to the child. But in this sense, it's an artificial passive. I don't know if you are getting it. Okay, so you can have the passive immunity. Passive immunity is when you are passing it on. So the passive immunity, depending on whether you're active, it was natural or artificial. When you are passing it on, it will also be natural or artificial passive. Please, have you gotten it? Have you gotten the concept?
Yes, sir.
Can someone summarize for me to be sure you've gotten it? Can someone summarize it?
So please, you said that for natural acquired immunity, the person gets measles virus, and then after the measles is gone, he naturally develops immunity against it. Now the acquired.
No, come again. Start with the innate. Start with the innate. Start with the innate or natural immunity.
So the innate or the natural immunity is the immunity that the child is born with. So, for example, the white blood cells. Okay. The child is born already with the white blood cells. So that is the innate or the natural immunity. Then we come to the active natural immunity.
Not only white blood cells. So give all the examples. So white blood cells, the hydrochloric acid in your stomach, your skin, your skin. Do you get it? Your phagocytosis, the white blood cells in your blood, all those are the innate. That is what we call the natural immunity or inborn immunity. Okay, so we have two types of immunity. We have two main types of immunity: the natural one or the innate immunity, and then we have the acquired immunity. Do you get it? All right. So we are done with the natural. Go on to the active.
Then the active.
No,
The
sorry. Go
active
on to
could also,
the acquired. The acquired.
okay. So the acquired could be natural or artificial.
Okay.
It is natural when the body is like exposed to the organism itself.
Okay.
It becomes natural active immunity.
Okay.
Then when the person gets it through like immunization or vaccination
Okay.
or a chemical structure, it
Okay.
becomes yes, artificial active
Active immunity.
Then
Excellent.
yes. Then the passive will depend on whether the person had it via natural or artificial. And so if the person had it natural and he gives birth to the child would possess passive natural immunity.
Excellent. So, for example, let me give you an example. Let's say
Yes.
a mother transfer maternal antibodies through the placenta or the breast milk. Where will you classify it?
Natural passive.
Yes, natural passive immunity.
Natural.
Okay, natural passive immunity. Is that okay? That is what we call natural passive immunity. Okay, good. So understand the difference. And then we have what we call the community or herd immunity. When we say community or herd immunity, that is when a large proportion of a community is immune against the spread of a particular disease. And usually we achieve herd immunity through vaccination, through mass vaccination. So when you hear mass community or herd immunity, when you hear herd immunity means like a whole population, they are immune against a disease. And most of the time, for we to achieve herd immunity, we have to do mass vaccination. Okay, so that's all that's about immunity. So immunity, we have two main types of immunity. We have innate immunity. Okay, so when we say we have innate immunity is the natural ones. You have it at birth, so it's present at birth. So like your skin, your white blood cells, your hydrochloric acid in your stomach, all those comes under innate or natural immunity. Then we have what we call the acquired immunity. Under the acquired immunity, that is where we have the active immunity and passive. When we say active immunity, for example, with the active immunity, under active immunity, we can have natural and then artificial. Natural means that you had, for example, measles naturally coming into contact with the organism itself. Then after coming into contact with the organism itself, you go through the disease, you recover, you form antibodies. Now you can have someone who will not come into contact with the measles naturally. The person will go to public health facility. They will inject a vaccination. The vaccination has the chemical structure like the organism. Then the person still form the same antibodies. So someone who had measles naturally and gets antibodies against measles, and someone who was given measles vaccine, the antibodies they will form is the same thing, just that one's own is a naturally active immunity, and the other one who went in for the vaccine, that one is the artificial acquired immunity. Okay, now someone who have developed a certain immunity, and usually the natural passive immunity is on the mother's side, it's on the female side. They will pass on to the child. Okay, so for example, a mother who have an antibody against a certain disease, pass it on to the child through the placenta. Do you get it? That one becomes, and if the woman had it naturally, okay, then it becomes a natural passive immunity. Do you get? So understand the differences. So we have two main immunity: the innate or the natural or inborn immunity. We have the acquired immunity. Under the acquired immunity, we have active immunity and passive immunity. Under active immunity, we have naturally acquired active immunity, artificially acquired active immunity. Under passive, we have naturally acquired passive immunity artificially acquired passive immunity. So if they tell you what is an artificially acquired passive immunity, you should know what it means. Do you get it? You should know what it means. Okay, so that is basically it for immunity. And if you say herd immunity or community immunity, herd immunity meaning a whole community receiving vaccination against a particular disease, a whole community. Okay, so basically that is it for the immunity, okay, and vaccination. Okay, that is it for immunity and vaccination. But when we say vaccination, what does vaccination means? When we say vaccination, what does it mean? When we say vaccination, what does it mean? Okay, so when we say vaccination, vaccination is like a process of giving a vaccine to someone. Immunization is a process by which someone becomes protected or immune against a disease. Usually, vaccination would help you become immune. Sometimes vaccination, but remember, immunity can be acquired naturally too. But mostly the purpose of vaccination is to make you to become immune against a disease. But someone can become immune naturally. Now you understand the different types of immunity. So I know you can explain. But remember that immunity is when you sort of become protected against the disease. You have protection against the disease. It could be natural or acquired. We've looked at that. But when we say vaccination is when we are giving you a vaccine to make you immune or to give you protection against a disease. Okay, that is the difference between the two. I think for now, I'll end over here. Okay, with the rest of the public health, okay, pay attention to the other sexually transmitted diseases like HIV, AIDS, tuberculosis. Sometimes they can ask you questions on the dot therapy in the general paper. So tuberculosis, HIV, AIDS, and pneumonia. Mostly they will ask you questions on the communicable disease and sexually transmitted disease like the chlamydia, trachomatis, syphilis. Okay, these sexually transmitted diseases. Make sure you revisit all these sexually transmitted. Know the causative organisms, know the signs and symptoms, and know their management, especially with their medical management and sometimes their side effects. Okay, I wish you guys all the best. Bye-bye.
Thank you, sir. Bye-bye.
Thank you, sir. Bye bye. God bless you.